Good morning, everyone.
Good morning, Dr. Ritu.
Mr. Bhalirao, I need to call you, right? For the corporate.
Corporate, yeah.
Yeah. Okay. All said, nobody's joined till now, na?
No, madam, joining. People are joining.
Acha. Now, about the questions, you will be sending them, or they'll come directly onto the chat box.
They will directly come when they click on the this link. They will directly come in.
Even the audience questions, na?
Audience questions will come on Q&A box. There is
Directly, na?
Yeah.
And second thing, you got Dr. Grandhi's presentation.
Sir, we got the presentation.
No, we didn't.
No, ma'am, we didn't get.
Abhi to right now there's no lag that we can feel.
No, it's actually lag is not there. If bandwidth is good, anybody can share. If any issues is there, so I can share my email ID.
Bede ma'am has Dr. Grandhi's this thing. Good morning, Dr. Vijay.
Good morning, ma'am.
Ready?
Yes, ma'am.
Good. All the best.
Ritu, good morning.
Good morning, ma'am.
How are you?
I am very well. I was just confirming. Mr. Bhalirao will do the corporate presentation, and I don't think there is any lag. So I don't think you've shared his Dr. Grandhi's this thing with them, na?
You want me to share, or Dr. Grandhi himself will try? Let him try first.
We'll see if we can. Otherwise,
otherwise there is a problem.
Yes.
Mr. Dr. Mangesh, sorry, the technical support. Can you promote Dr. Rashmi Soni also as panelist?
Okay, ma'am. Yeah, I'm doing.
And DJ Patil sir is done, na?
DJ Patil sir also will join here. We will keep telling him. DJ Patil sir, Dr. Taude sir, Patwardhan sir, and Muttalik sir. These are 4 people other than our list program people. So you have to keep promoting them to this.
Rupesh, note down these names.
I'll tell you, Dr. N.G. Patwardhan.
1 minute, ma'am.
You can Ritu. You can.
I'll write it down.
Chat box.
Ma'am, you just watch who is in attendee and tell me the name. I will promote as a panelist.
I'll write down the names in the chat box.
Okay, fine.
Yeah, we'll keep watch on them.
Rashmi Soni, have you promoted her? Dr. Rashmi Soni Lohia.
Yeah,
I'm trying, but ma'am, she is not accepting. I'm trying.
She has to accept.
I will
Dr. Rashmi, ma'am, you can accept. Yeah.
Yeah.
And one more thing I wanted to know, like some people have not registered actually, and they will try to join in right now spontaneously.
They can join directly. Click on the link, ma'am. Just share this link we have provided with you. They can join the program on this.
Even if they have not pre-registered.
Yeah,
right?
yeah.
Okay, thank you.
I've sent you the names: Dr. N.G. Patwardhan, Dr. Sharad Mutalik, Dr. DJ Patil, Dr. Taude. And Dr. Rashmi. You got the names, right?
Yeah.
Dr. Vijay is here, right?
Yes.
Dr.
Vijay, have you tried sharing your screen?
Yes, ma'am.
He tried, na?
He tried that day. Now, Vijay, just try once more, now.
And see if there is echo, because last night there was some echo when we were having practice.
Day before.
It shows host to disable the participants' screens there.
Allow him to share the screen, please.
Rupesh, allow all panelists for the presentation share.
There won't be any disturbance from the other people, right, on this link? No, he is muted.
Hello.
That's fine.
Yeah.
Is it visible, ma'am?
Screen.
Please go on to the first slide. Put it in a power. Move ahead. Yeah.
Perfect.
Good, good.
Just try saying something, na, Vijay?
Hello, good morning, everyone. Myself, Dr. Vijay Desai, first year resident doctor in dermatology department.
Perfect.
Good, good, good.
And when I just needed to ask, ma'am, when I say there'll be a case presentation by Dr. Vijay Desai, I don't need to say which case, right?
You don't say that we have put it in
because,
the invitation, and
yeah,
then the whole impact will go.
Right.
Yeah.
Good morning, ma'am.
Good morning, Rashmi.
Good morning, Ritu.
Good morning.
Rashmi, do you want to share the screen and
हाँ
see?
मी तेच
Yeah.
share करून बघते.
And Ritu, you just wait for a moment till the slide.
Till
is
the
on
slides.
screen, yeah.
Right.
Vijay, can you stop sharing or?
Vijay?
Yeah.
Tavde sir is here. Good morning, Tavde sir.
Good morning, sir.
Tavde sir, good morning.
Good morning. Good morning, everybody.
Good morning.
Can you see the slides, Ritu?
Yes.
Yes.
Yes. Perfect.
All right.
And Doctor, this mud case?
Sorry?
Rashmi, Dr. Matkes you've added, na? I didn't see his.
No, wait. I added according to the program. Which one?
Yeah, 1 second. See,
Yeah.
first is Dr. Grandhi, then Vijay
Yes.
Desai, then Bhushan Matke. Second, now Dr. Matke.
No, I don't have a CV. I added. Yeah.
It's there. It's there.
Yeah.
Yeah. And then after that,
I
Kiran
didn't hear the name properly, so I was wondering who you're talking about.
Kiran Ardar,
After that is Kiran, then
Sardesai sir, and then Krupa Patel.
Yeah. All of them are there.
एक मिनिट सुधाकरनी फोटो पाठवलाय का चेक करते असेल तर तुला
हो मी टाकून देते मॅम नो प्रॉब्लेम
त्यांनी आय कार्ड फोटो पाठवला मी तुला व्हॉट्सअप करू
हो मॅम करा
पाय 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 धुवायला जात नाही आणि तू आता पाठवलेलं आहे सगळं की त्यांना सगळ्या घरात धुवून जायचं आपण तुझी नाटक करू
And I would request the people who wants to speak, they can unmute themselves and others have to. Or what we'll do, if voices are there, we'll unmute everybody and the person who wants to speak can unmute.
But audience will be muted, na? Anyway.
Yeah, audience would be those who are attendees. Those who are attendees, they would be muted.
Mangesh.
Yes, ma'am.
Dr. Sardesai has joined, so please promote him here. Vasudha Sardesai is the name of his device.
Yeah, ma'am. Promoting.
Dr. Krupa Patel also has joined. Please promote her.
Yeah, ma'am. Promoting.
Light बंद करो.
Nitin.
Good morning, everyone.
Good morning, Krupa.
Good morning, ma'am.
You want to share?
Hello.
Hello. Good morning.
येतं ऐकू?
Oh yes. Share करून बघ.
हो बघतो.
Registration किती झालेत आतापर्यंत?
I need to check, ma'am.
हाँ धनश्री
हा बोल.
1 मिनिट शेअर
हा येस आता दिसायला लागलं. येस येस.
दिसतंय 1 मिनिट.
हा दिसतंय दिसतंय.
दिसतंय?
येस येस.
Yes.
थोडं पुढे मागे करून बघ. हा
ठीक आहे ना?
येस.
हा.
आणि सगळ्यांना सांगून ठेवते की देर इज एनी टेक्निकल ग्लिच विथ एनीबडी वी विल स्टॉप दॅट प्रेझेंटेशन वी विल गो अहेड विथ द नेक्स्ट प्रेझेंटेशन अँड वी विल टेक दॅट प्रेझेंटेशन इन द एंड. सो डोंट पॅनिक and we will not waste time also. We will move on to another speaker. Okay.
Yes.
Kiran, good morning.
Good morning, ma'am.
Try करून बघ एकदा.
Yes.
Dr. Mangesh, Dr. Rohini Gayakwad also has joined, so please promote her here.
Yeah, ma'am. Promoting.
थोडं बोलून बघ बरं.
Good morning, everyone.
बरोबर.
Good morning, Dhanishri.
Good morning,
Good morning,
Rohini.
ma'am. Good morning, Ritu.
Can everyone switch on their videos? I will click one photo. Hi, good morning, Sudhakar.
Hi, good morning. Good morning, everybody.
Good morning, sir.
Please
Please check his first, his slides first.
चष्मा काढ ह्याचा. Yes.
Sorry.
ऐकायला येत नाही. म्यूटच नितीन. हा.
Ranvi sir, do you want to check your slides?
Yeah, I'll do that. 1 minute. Yeah, I think I've screen shared.
Yes.
Yes.
Visible? Or I'll make it full screen now.
Yeah.
Yeah, I think it's okay.
Yes.
Yeah.
Yeah.
Can you speak a few words so that we will know whether there is a lag or not?
Can you hear me clearly now?
Yes.
Yes.
No problem?
No problem. Rupesh, no problem, na? With Dr.
No, ma'am. No, no problem.
Yeah. Can you stop sharing now, Sudhakar? Yeah. So 9:55 sharp we will start. Rupesh, you can give us a countdown timer and we will take hard stop 3 minutes before that.
Yeah, ma'am.
तिन्ही मुलं जॉईन झाले तर हे दोघं जॉईन झाले. भूषण नाही जॉईन झाला अजून.
भूषण मडके.
भूषण होईल थोड्या वेळाने.
Bhushan Madke is there?
No, he hasn't joined. He hasn't. Sudhakar, good morning.
मी म्हटलं सरदेसाई सरांशी बोलू का?
हा, त्या निमित्ताने तुमचं दर्शन झालं.
हो अगदी अगदी अगदी.
हा, भूषण आला. भूषण, गुड मॉर्निंग.
गुड मॉर्निंग सर. कशा आहेत सर?
हा, बर मस्त. हाऊ आर यू?
आय एम फाईन सर. आय एम गुड.
So do you want to check your slides.
Me?
Yes.
Okay. Just. दिसतंय का?
Yes.
Yes.
Can you make it full screen and check once? Ah, perfect.
ठीक है?
Yes. Can you just talk a little more? I feel there's a slight lag.
Hello, good morning everyone. How are you?
Okay. Yes.
Yes, good.
ठीक है ना मैडम?
Yes, yes.
Yes, ठीक है.
Okay.
Can you stop sharing please? जरा सगळे परत व्हिडिओ ऑन करा ना, ह्याचा फोटो नाही आला करा. Yes, विजय तावडे सर, डॉक्टर मंगेश. Yes, thank you.
किती वाजता चालू करणार आहे मॅडम आपण?
9:55 sharp.
Okay.
Ma'am, should I once go ahead and check my?
Yes, please. Yeah.
Yeah. I'll share my screen then. It's visible, no, ma'am?
Yeah, it is visible. Can you say a few words?
Good morning, everyone. I'll be presenting 2 interesting cases today.
Yeah.
Okay.
Yeah, okay.
धनश्री,
हा बोल.
माझा आवाज येतोय ना? मी माईक नाही घेत मग.
हो नको घेऊ, हे व्यवस्थित येतं कारण ते कधी कधी माईकने गडबड चालू होते.
हो, मग हे ठीक आहे.
हे ठीक आहे आणि व्यवस्थित येतो एकदम, काही प्रॉब्लेम नाही. Mr. Rupesh,
Yes, ma'am.
काही अटेंडीज ना लॉगिनचा प्रॉब्लेम आला तर तुमचा नंबर शेअर करू का?
Yeah, sure, ma'am. No
Can
issue.
you type it here or you can tell me your number?
My number,
Huh.
I will type in the chat box.
Yes, please.
Also, will you give a hard stop at say 9:54?
चॅट बॉक्स दिसतच नाही मला.
Huh?
मला चॅट बॉक्स दिसतच नाही.
चॅट बॉक्स मॅम खाली आहे, बॉटमला असेल.
नाही, I mean, I am not able to see. Now I can see. His number, Rupesh's number.
रुपेश नंबर टाइप करते.
हा मॅडम दिलाय.
81 काय आहे तो ना?
81496305.
मॅडम क्वेश्चन आन्सर आपण कसे घेणार आहे, म्हणजे कोणी सांगणार आहे आपल्याला की कसं चॅट बॉक्स मधून बघायच्यात आपल्याला?
नाही,
we'll ask.
Ritu will ask, yeah.
If there are any in the chat box, I'll ask.
Dr. Ritu will ask?
Yes, if there are any in the chat box.
Okay. She will keep a tab on chat box and then she will convey to us.
Yes.
Yeah. And simultaneously, me and Dr. Rashmi also would monitor them, in the sense like we will try and write it down here so that no questions are missed.
Okay. Okay. लॅपटॉप.
Ma'am, it's 9:50. Now we can go live.
You tell me when to start.
Now we are live, ma'am. We can start now.
Start. A very good morning and a warm welcome to you all from the Pune chapter of IADVL. Today's CME is on drug reactions. Drug reactions are commonly encountered in our day-to-day practice and can be very perplexing due to overlaps in clinical manifestations. Today, we have case presentations and talks on various drug reactions like Erythema multiforme, SJS 10 by residents and eminent speakers. So without any further ado, I would like to invite our president, Dr. Dhanashri Bhide ma'am, for the welcome note. Over to you, ma'am.
Thank you, Dr. Ritu. Am I audible?
Yes, ma'am.
Yeah. So good morning, everyone. Today, as Dr. Ritu has said, we are going to discuss all different types of drug reactions in the CME. So when we are in an emergency room or when we are in our OPD, we see patients coming to us with history of various drugs. Right now in COVID era, patients are on different drugs. plus elderly patients on polypharmacy, and they have lesions like target lesions, they have flat lesions, purpuric lesions, and when you look at them, you really don't know in which spectrum this patient fits in. And I feel it is extremely important for us to identify one from another, because the management is totally different, and especially patients of toxic epidermal necrolysis, if you diagnose them very early and introduce cyclosporin therapy on time, it is life saving, and the mortality can be very, very low in this kind of situations. So to understand the clinical features, to understand the pathogenesis, we have invited senior dermatologists, and to show us the real life case scenarios, we have the students from our KEM hospital, Pune. So if you can identify the clinical signs and symptoms and the distribution, because most of the times the diagnosis is clinical, you don't have time to wait for the histopathological report, and the morphology and distribution, as in any other dermatological conditions, definitely helps us to conclude and have a specific diagnosis. So we have invited today Dr. Vidyadhar Sardesai. Dr. Sardesai is known for his very crisp presentations, and he has a vast teaching experience of more than 30 years. We also have with us Dr. Sudhakar Grandhi. Sudhakar Grandhi is a private practitioner. He has a huge practice and a vast clinical experience. We have also invited Dr. Bhushan Madke. Bhushan Madke's knowledge we all are aware of. You put any query to him and he is the fastest finger first kind of a person, and his strike rate is 100%. So we have such eminent seniors to guide us, and we have Dr. Vijay Desai from KEM Hospital, Pune. Vijay is known for his perfect record keeping, and he also has interest in dermatopathology, so he always will correlate the clinical photographs and keep a very good record of them. We have Dr. Krupa Patel. Dr. Krupa Patel again is a resident in KEM Hospital, Pune, and Krupa is very popular in patients. She is very soft and very empathetic. So she is the most wanted resident by all the admitted patients. And we have Dr. Kiran Adrat. She is also from KEM family. She has recently passed out from KEM and now has started her own private practice. Kiran also is interested in clinical dermatology. She is very quick in understanding, and she has interest and inclination towards publications. So with such a varied panel, we will definitely have a very interesting session ahead. So without wasting much time, I would now hand over the session again to Dr. Ritu Chote. Thank you very much.
Thank you, ma'am. Before we begin, I would like to go over the housekeeping rules. I request the audience to keep their videos and mics switched off. Question and answers will be taken up at the end of each talk. So I request you all to post your queries in the chat box. Our first talk is on erythema multiforme by Dr. Sudhakar Grandhi, sir. He completed MBBS and DVD from BJ Medical College and has been practicing since 1991 in Pune. He's a consultant dermatologist at MediPoint Hospital, Pune, Sevadham Hospital, Talegaon. And he worked as a project manager in leprosy eradication scheme of Sevadham Trust for 10 years and implemented government leprosy project in Pune city and Pune district covering a population of 7 lakhs. He's held many camps for leprosy and has also worked in AIDS awareness and detection program and has special interest in acne and leprosy. Over to you, sir.
Thank you, ma'am, for your introduction. Today's topic is a very challenging case, a topic because we find it very commonly in our clinical practice. I will be giving a brief overview on erythema multiforme, its etiology and its practical management tips.
Dr. Sudhakar?
Yeah.
Do you want to share your screen?
Yes. Yeah. Yes. with this, I will start the topic. As you all know, erythema multiforme is quite common in our practice, though it is said to be up to about 1% of the population. We do come across clinical presentations in varied forms, which we often miss. And it is best regarded as a self-limiting cytotoxic dermatitis resulting due to cell-mediated hypersensitivity to drugs and infection. Though today's topic is about drug interactions, in erythema multiforme, drugs are not a very major cause. Primary cause is, of course, the infections. The classification-wise, erythema multiforme was initially clubbed together with SJS and TEN. However, nowadays, the classification says erythema multiforme and minor are one group of diseases, and Stevens-Johnson syndrome and toxic epidermal necrolysis are another type. The term erythema multiforme was first coined by von Hebra. As I said, the incidence is less than 1%. It's predominant in young adults with a slight male preponderance, and recurrences are known in up to 30% of cases. Etiology-wise, the pathology is an immunological basis. It's thought to be a hypersensitivity response, and HLA studies have shown an association with HLA B62, B35, and DR53. Now, coming to the important point, that is the triggering factors. There are multiple triggering factors involved, and I will briefly go through the list. The first point we have to consider is infections. And infections, viral infections, are the mainstay of causing erythema multiforme. Amongst the viral infections, the commonest viral infection which causes erythema multiforme is the herpes simplex virus. So any case of erythema multiforme presenting in the OPD basis, I would first try to look for herpes simplex infection, take a history. Out of HSV, HSV1 is most common, but HSV2 can also cause erythema multiforme. And if you have a patient who comes with recurrent erythema multiforme and in his history, you have to consider herpes simplex as the primary cause. Other reasons are Mycoplasma pneumonia infections. Actually, till I started seeing for this slideshow, we really did not look for Mycoplasma pneumonia, but it has been mentioned as the second most common cause of erythema multiforme. Now, when to suspect Mycoplasma pneumonia? If it is a child with erythema multiforme, if the patient has got severe conjunctival corneal involvement with erythema multiforme lesions, you should think of Mycoplasma pneumonia. Other reasons which are other viruses involved is HIV, adenovirus, CMV, varicella, hepatitis C. Bacterial infections, many bacteria are also implicated. Rickettsia also have been implicated. Fungal infections like histoplasmosis, candida, and drug reactions is now the other reason which we have to think. Commonly, many drugs list is there which cause erythema multiforme. Though they have been implicated, up to 10% of cases of erythema multiforme are thought to be really due to the drugs. In practice, of course, when a patient comes to us, we would like to easily say, this was the medicine you have taken, so that is why you have got. But what happens is the patient may have already had an infection of herpes simplex. He might have taken medicines for that infections and then presented with erythema multiforme, and we may attribute the cause of erythema multiforme to the drug rather than to the infection. Documented evidence says only up to 10%, not more than that, are causative factors as drugs as for the erythema multiforme. Now, what are the drugs? We had a mnemonic long back called PPP: penicillin, phenylbutazone, and phenobarbital. These were the commonest drugs which we always used to keep in mind, and the class of drugs which these drugs belong to. So antibiotics, penicillin would be the first. However, we don't use it now. Ampicillin is another class of that. Sulfonamides are known to cause cotrimoxazole, sulfones, tetracycline, cephalosporins, quinolones. Amongst the antifungals, griseofulvin, terbinafine, commonly. Fortunately, itraconazole is not in this list much because we are using it so commonly nowadays. Antiretrovirals, abacavir and nevirapine, and the non-steroidal anti-inflammatory drugs like ibuprofen, phenylbutazone, paracetamol, salicylates. Anticonvulsants, the barbiturates like phenobarbital, carbamazepine. And other miscellaneous drugs like antihypertensives and allopurinol, cyclophosphamide, progesterone. An interesting point was vaccinations are also known to cause erythema multiforme. This was seen in children who were given routinely vaccinations. Nowadays, however, we have a vaccination campaign of COVID vaccination, and there are reports of mRNA vaccines causing the erythema multiforme, but we will have to wait for further evidence to see how true the evidence is or the case reports are. Other vaccines of the corona vaccines, no evidence as yet has come. One interesting point of etiology is topical agents also can cause erythema multiforme. And as a dermatologist, this is a topic of interest for us because many patients come with topical reactions and then they may get erythema multiforme, which sometimes we put it as a id eruption. So what the report says, topical sensitivity or sensitization can cause a erythema multiforme also. So potent sensitizers like DPCP, poison ivy, of course, and topical medicines like chloramphenicol, furazolidine, mefensin, neomycin creams, which we all know causes topical sensitivity, may induce erythema multiforme. Ophthalmic drops like tropicamide also can cause. Sometimes a patient presents with a sensitivity like rash around the eyelids with drops, and then we give some medicines and later on he gets a rash all over the body. So we have to look whether the drops itself triggered off the erythema multiforme. PPD in hair rise, the paraphenylene diamine content, blister beetle dermatitis, nickel formaldehyde and rubber gloves are all known to trigger off topical agents, all topical agents known to trigger off erythema multiforme. Coming to the clinical features, erythema multiforme will be classified as minor and major. The minor one is very commonly seen, and fortunately for us, it is not life-threatening. It can be managed on an OPD basis. So in minor cases, 80% of the erythema multiforme cases are erythema multiforme minor. We get as macular, papular, urticarial lesions, erythematous lesions, and of course the classical target or iris lesions are seen. The lesions are predominantly in acral distribution, and then they may slowly spread on the trunk. This contrasts with SJS, in which the lesions are predominantly centripetal. So that is a differentiating factor clinically for us. The lesions may involve the palm, trunk, oral, genital mucosa also. Target lesion, we have all seen in a practice. Classical, it's like a bullseye. When an archer hits the target, you know the target has got concentric rings. So this target lesion also has concentric rings, and there are usually 3 zones in it. The size varies from 1 mm to up to 3 centimeters. And there is a central area of dusky erythema, which is then sometimes purpuric later on, and maybe even a vesiculated lesion in the center. And then there's a middle pale zone of erythema, and then an outer ring of erythema with a well-defined edge. Sometimes on this edge, we see tiny vesicles. It's studded with vesicles, and that has been called as the herpes iris of Bateman. Coblerization is common, and photoaggravation is also seen. Erythema multiforme major is the second one. In this, the lesions are more. They may involve up to 10 to 15% of the body surface area. Mucosal lesions are more, and the mucosal lesions are quite often severe. Oral mucosa is most commonly involved. Point to be noted is the hard palate is usually spared. The mucosal labial, the buccal, and the lip area is involved, and this causes morbidity to the patient. Ocular involvement, a patient can present with conjunctivitis and later on complications. Genital lesions are seen. Pharyngeal mucosa involvement also can be seen. Sometimes the erythema multiforme major patients present with a prodrome, and this may be due to the viral cause or the infectious bacterial infection cause. They present with fever, malaise, feeling of illness. Later on, of course, once the rash onset has come, fever is there, there's a pain in the mouth, cervical lymphadenopathy, sometimes urinary retention because of the painful lesions on the genitals. And if there is, the reason is the trigger is the Mycoplasma pneumonia, then patient may have cough, dyspnea, and even hypoxia. Classical target lesions, few photographs to show that. This is the central erythema and then the pale erythematous zone after and a clear-cut border. And the second picture shows a little vesiculation or almost like a blister formation in between. Of course, the lesions on the palms are classical, multiple lesions. This was just to show you the small ring of vesicles on the periphery, the so-called iris, the herpes iris of Bateman lesions. Again, a small child with crusted lesions on the lip. Without the other lesions of the skin, you would not like to put it as only a erythema multiforme. It can fit into many other lesions. Again, a classical sign, multiple targetoid lesions. With some lesions like this, the clinical diagnosis becomes very easy for us. And this is a lesion, multiple lesions which are coalescing and seen in a case of erythema multiforme major. Now, what would we like to do as investigations? My investigations as a practitioner in an OPD basis would be baseline studies initially. You can do a CBC with the ESR and ESR would be raised. The CBC would help us if there's a bacterial etiology, the WBC counts would be definitely very high. And of course, if the patient has not received steroids, we should, if they have received steroids already, we should ignore the WBC counts if they are raised also. Then an LFT, a renal function test, a urine routine, and then to evaluate the cause, you have to evaluate for HSV1 and 2. Most labs are doing the HSV serology. We just send it for HSV1 to IgG as well as IgM. IgM will give us the indicator that there is an active involvement of active infection. Most labs do it and costs are not very expensive, so we should order a HSV1 and 2 test. We can do a Zank smear for HSV from the erosive lesions, if possible. That will also give us a clue to the viral etiology. And for evaluation of Mycoplasma pneumoniae, you have to do an X-ray chest and you can do an IgM, serum IgM levels, test for the antibodies for Mycoplasma pneumoniae. A throat swab PCR is maybe in specialized labs, and if required, an HRCT can be done, depending on the clinical condition of the patient. And HPE can be done mostly in clinical because by the time the reports come, the disease has started involuting. We may not do it, but if we do it, we do get a clinical picture, which is quite classical for erythema multiforme. Now the histopathology will show a epidermal necrosis. There will be an epidermotropic lymphocytic infiltrate, and there may be basal cell liquefaction, and apoptic cells also will be seen. The infiltrate is moderate. It's not a very dense infiltrate, and it's a lymphocytic predominant infiltrate, which may be in a lichenoid pattern and may obscure the dermoepidermal junction. Sometimes if it is a biopsy is taken later on, in a later stage, you may get vesiculation, you may get subepidermal clefts. The point to be noted is the oral lesions and the skin lesions, the histology is quite similar. So even if we suspect only oral mucosal involvement, we may do a biopsy even before the skin lesions erupt. This is just to show us what it looks like. We can see the necrotic keratinocytes, some spongiosis, then there's a lymphocytic infiltrate, which is towards the epidermal cell layer, and a perivascular lymphocytic infiltrate. This is again to show the variable infiltrate of the lymphocytes, mainly at the dermoepidermal junction. Again, showing the lymphocyte. Now, this lymphocyte may fit into many other disorders also. This was just a patient had brought a report showing drug sensitivity, drug allergy screening test. Many patients do ask, can you tell us the cause of the drug? Which drug? Are you sure that is it? And sometimes they go for an allergy test for the drugs. The report will show us commonly induced drugs, and like we do allergy testing for food, these reports are brought by patients many times. How often we can depend on it is of course a conjecture. But if there is a clinical history of consuming a particular drug and the report confirms it, we are doubly sure. Some labs are doing it. It's not routinely done in all the labs. Many drug labs have their own screen for drug tests, and some labs do individual drug testing also. So if the patient suspects a drug, say paracetamol, we can advise to do only for paracetamol to save on the costs. Differential diagnoses are multiple. The lesions are of multiple pathology, etiology, and the diagnosis also is multiple, differential diagnosis. Of course, Stevens-Johnson syndrome is the first because the etiology is similar in most cases. Stevens-Johnson syndrome would be more severe form with lot of mucosal involvement and morbidity. Fixed drug eruption and drug eruptions, clinically we can find out because they will be lesser in number. The targeted lesions may not be so prominent, and there may be history of older eruptions with a PIH. Bullous pemphigoid, again, many times a patient comes with bullous pemphigoid later on with lot of excoriations, vesiculations, erythematous-based lesions, and they are confusing with erythema multiforme. Sweet syndrome, multiple plaques would point towards sweet syndrome. Ravel syndrome is actually lupus erythematosus with lesions of erythema multiforme. Of course, we have to look for other signs of lupus like malar erythema and maybe other lesions of lupus, which would give us a clue to clinical diagnosis that this could be Ravel's. And then we have to do the dsDNA tests and the other routine investigation for lupus. PLE is one more differential diagnosis, vasculitis, urticaria, and paraneoplastic pemphigus is also mentioned in the list. Clinical course, as I had said already, the erythema multiforme minor has a very mild self-limiting course. So usually the lesions keep appearing over a period of 5 days, and then they start resolving over a couple of weeks. In the cases of erythema multiforme major, where the lesions are large and confluent, the lesions may take up to 6 weeks to resolve. The lesions usually resolve with only PIH and no scarring. However, the patients may have severe edema of hands and feet, and the pain of the oral lesions may increase the morbidity. The skin lesions, as I said, do not scar. Ocular involvement can cause keratitis, uveitis, or even visual impairment. In severe cases of erythema multiforme, there may be strictures, esophageal strictures, sometimes pneumonia. These are quite rare complications, especially in erythema multiforme minor. Now, clinical course is self-limiting, but there are a subset of patients, up to 30% almost, who have recurrent erythema multiforme. And in some patients, there is mentioned as persistent erythema multiforme. We'll just look at those patients later on. Now, the management-wise, erythema multiforme diagnosis is an important point, because management for erythema multiforme minor is only usually symptomatic, especially for the minor cases which are minimal. But we have to look for the cause so as to prevent the recurrence in future. So all the inciting factors, especially the suspected drugs, have to be stopped. In this era of polypharmacy, it becomes very difficult to stop all the medicines. So we have to go back to our list, look at what are the common implicated drugs, maybe talk with the physician and avoid most of the major drugs, look for newly added drugs, and past history of drug hypersensitivity, if at all. Again, drug testing, as I mentioned, we may or we may not do, because the result also takes time to come. So first of all, we have to primarily stop all the implicated drugs. Then, if for the treatment-wise, topical antibiotics on the oozing lesions, crusted lesions, we can give calamine lotion as a soothing lotion. Oral antihistamines are given. Oral steroids, the role is not clear. It's controversial, but we do give oral steroids initially for a short period and then stop it without tapering. If mycoplasma pneumonia is suspected, we can do the IgM studies and start on antibiotics for mycoplasma pneumonia. because we would like to avoid the complications of chest involvement, which may become quite severe. The Mycoplasma pneumonia antibiotics commonly used are the macrolide group, and we can use azithromycin, erythromycin, or clarithromycin. Tetracycline also is mentioned, but I would hesitate to use that, especially in children. So better we go with clarithromycin or azithromycin. Then if severe mucosal lesions, of course, admission is required because the patient has a poor oral intake, admission with IV fluids, and critical care may be needed if erythema multiforme major is there. So better admit in an institute where we have access to maybe ICU or a good wound care, something similar to SJS or TEN. And ophthalmic referral is a must if there are lesions on the conjunctiva. Now, coming to recurrent erythema multiforme, these patients may need suppressive therapy with acyclovir because, as I have mentioned, most of the cases of recurrent erythema multiforme are due to the herpes simplex virus. So we do put the patients on acyclovir 400 mg twice a day for maybe up to 3 to 6 months continuously, and then evaluate after stopping the acyclovir whether they are getting again attacks. Other drugs mentioned for treatment of erythema multiforme is azathioprine, cyclosporin, dapsone, and thalidomide. Cyclosporin works as a rescue drug, especially in erythema multiforme major with lot of mucosal involvement, and of course in SJS, which I think the next speaker will be telling. With this broad overview, I think I will hand over the mic to the next speaker who will give us, Dr. Desai will tell us about the clinical case presentation. And thank you all for a patient listening. Thank you.
Thank you, sir, for a very nice presentation. We'll go on to the questions now.
Yeah.
First question is there a difference in the clinical manifestation and presentation of erythema multiforme triggered by herpes simplex and drug-induced erythema multiforme?
Yeah, if it is a viral infection, the lesions are usually not so severe and they may have a usual progression of disorder. But if it's a drug-induced, you get an abrupt onset with multiple lesions everywhere. The lesions will be the same, but.
And there's another one which I think we are done.
Can't hear
And
you.
you have no. Do you have any questions, ma'am?
Yeah. Actually, Dr. Sudhakar, in your practice, what is the commonest drug that you have come across, like as far as the culprit drug in erythema multiforme?
Commonly, I've seen cotrimoxazole and ampicillin-induced drugs, the ampicillin class of drugs.
And I would like to know from other panelists also about the Mycoplasma pneumoniae, because in the infection list, one is herpes simplex and the second one is Mycoplasma. And I am into practice for almost 30 years and I haven't come across a single case of Mycoplasma pneumoniae. So are we missing it or it is rare in Indian circumstances? So
I think actually we are not doing it. We are not checking for.
Should we be checking it and how do we go about it?
I have at least not checked till now.
Yeah, I also have not. So, Dr. Bhushan, can you elaborate?
Yeah, actually, I think it is now time that we should include this Mycoplasma IgM serology in our workup, because as such, HSV is mainly a clinical diagnosis. We get few lesions of HSV either around mouth or some penile areas, and it doesn't need much serological investigation. But since Mycoplasma is a systemic type of infection, maybe a sore throat or otitis media, and we may not be able to seek frank because it simulates other viral infection only. So serology should be done, in my opinion, ma'am.
Yeah, and or is it like serology? How long it takes for the report to come? It comes in a day or two, or they send it to
around 5 or 6 days. It needs to get positive. IgM titer to rise. It's usually for majority of the infection. It takes around say after 5th day.
So then, like actually in the practice, we cannot really wait for 6 days.
Mainly it's a retrospective diagnosis that maybe the episode was because of Mycoplasma pneumoniae infection.
So then is it like if we suspect some sore throat, preceding onset of sore throat and other things, is it worthwhile adding a prophylactic antibiotic, maybe the macrolide?
And majority of the times, many physicians add azithromycin. So that is a very good cover for mycoplasma. Yeah. So it would be just an academic exercise retrospectively to do a serology and see.
Yeah, agree.
But that will prove that majority of the cases are retrospectively diagnosed as mycoplasma pneumoniae. So this will find way into our literature, which is only now like limited to only HSV.
Yes, I think after this CME, those who are attending at least would start doing it, and we would have more data accumulated.
Yes.
Yeah. So that can be done. Dr. Bhushan, I want to know from you, like in this COVID era, have you seen patients who were COVID positive or were having active infection presenting with erythema multiforme?
No, ma'am. Hardly I have seen. In fact, I have not seen much of the clinical manifestation in my part of the city. Hardly chilblains, but there were few urticarial eruptions, and like we get severe urticaria with many viral infection. I have seen most of them, and hardly erythema multiforme or chilblain like lesions. I have not seen, or frank gangrene. I have not noticed yet.
Yeah, so we have seen more of urticaria rather than erythema multiforme. I think Dr.
Yes.
Sudhakar, you also would.
Yeah. We see only hair loss a lot.
Yeah, hair loss is now like
that is what we see.
Yeah, 6 or 8 weeks later.
Yeah.
But during acute episodes, we hardly get any skin manifestation in majority of the patient, ma'am.
Urticaria is the only thing.
Yeah, urticaria is the only one.
And how about vaccine-related erythema multiforme?
No, urticaria only I have noticed.
Yeah, I also have noticed only urticaria. Dr. Sardesai, you are in an institute. So what is your experience? And your institute is having COVID centers. So what is your experience different from what we said? Vidyadhar?
I think he's not there.
He's not there.
Hello. Yeah. Actually, we in fact are going to publish an article where it's accepted for publication. And I agree with Bhushan and Sudhakar that in acute stages, absolutely no manifestations of skin as such, of COVID. We are seeing it later on.
Yeah. Dr. Sudhakar, you talked about the allergy testing for the drugs. So is it easily done in many labs, or we have to select a specific lab for that? And how costly are they?
Now the cost-wise depends on lab to lab. Some labs are collecting the sample, and I think Metropolis Golwilkar is doing it. Some labs are doing individual testing. That would be more cost effective. They charge almost 1,200 rupees per test. And if you do a screen, then it goes about cheaper. It's like a bulk package. But if you do for each individual drug, 1,000 to 1,200 per drug they're charging.
Works out cheaper, right?
Whether it is really worth, and it's something like your skin testing for allergy, food allergens, which we advise, and patients bring the reports and we have to take it with a pinch of salt.
So it's more of a patch test kind of a thing, right?
Yeah, it's not a patch test. It's on the serum.
It's on serum?
Serum, blood sample.
Serum test, okay.
Blood sample only.
Yeah, because re-challenge is not possible. So
re-challenge is difficult, dangerous.
Yeah, it has a lot of other implications. So it is not possible. And
it will only give us, it will only give us a confirmation that this was the drug.
Yeah.
If at all.
Yeah. And what about the topicals? Like how many of you have come across the erythema multiforme to topical agents? Because again, when you read the chapter, the topicals are also there in the list. So have anyone of you seen that kind of a thing? Dr. Bhushan?
No, ma'am. We use so many topical antifungal, topical antibiotics, or topical steroid. Hardly any case in last decade I have noticed any case. I'm not. Maybe other panelists can chip in.
We do not iris lesions, but many times we see topical induced ED eruption, we call it, in which body is symmetrically involved with multiple lesions. Maybe we are missing out and looking at iris lesions for that. We need to look.
Maybe that could be, sir, because of say a local allergic contact dermatitis spreading systemically, giving rise to ED eruption. But that won't, we can say it's to be an adverse drug reaction. It is more like an allergic contact dermatitis.
And I want each one of you to tell the attenders like the role of steroids. We always say controversial and we all tend to use steroids. So in erythema multiforme minor and in erythema multiforme major, what is your line of management? We will start with Dr. Sudhakar.
In erythema multiforme minor, we can do without giving steroids. But
Without
major,
oral-
I definitely, yeah, major, I would definitely like to give a short course. Though,
Short course.
yes.
Under cover of antibiotic or only short course?
Antibiotics, and as already mentioned by Dr. Bhadke, azithromycin we better give.
Yeah.
Because it can cover the cause also. Yes.
And erythema multiforme minor, you would probably go with topical steroids only. If it is not
Topical
major.
steroids, topical antihistaminics, and azithromycin or some macrolide antibiotic cover.
Do you agree, Dr. Bhushan, or any difference?
Yes, ma'am. In contrast to SJS-10, where we use a very high dose of pulse steroid, fortunately in erythema multiforme, major and minor, the dose is say oral prednisolone equivalent 30 or 40 milligrams, say around 7 to 10 days, which doesn't add much to the risk of say secondary bacterial infection like that under a good antibiotic and antiviral cover. So it is well educated, and I do use oral corticosteroids, especially in HSV. I don't use per se in SJS and TEN cases.
And what about prophylactic antiviral to each and every patient of erythema multiforme? You prefer to use acyclovir or valacyclovir, or you give it only to those who have history of recurrent herpes simplex? What is the strategy?
I think
Antivirals. Sudhakar, you want to?
Antivirals, if it is clinically documented or with serology documented as HSV1, definitely we have to give. Now, if we are suspecting whether to give an antiviral is not, it will not really help, because after the infection has occurred, the erythema multiforme comes. And to give an antiviral after that, just for the episode, I would not like to give.
So only if there is a history you would like to add, otherwise you don't.
History also, and if it is
proven, yeah.
Recurrent.
What about Dr. Sadesai, you want to add something?
No, I think I too agree. But if there are predominantly oral lesions, even then I think we should go in for antiviral. That's what I feel at times. The skin involvement less compared to the oral involvement, then give an antiviral.
And as HSV is very common infective cause for erythema multiforme, there is no harm in adding, I think so, because as it is, these antiviral drugs are skin rash wise very safe, because we haven't seen patients coming to us with skin rashes because of antiviral drugs. So I think that can be a safe addition to the practice.
Yeah, ma'am, maybe I'm not very sure. This is my hypothesis that few episodes of erythema multiforme may be associated with asymptomatic viral shedding also.
Yes.
So yeah, so to counter that asymptomatic viral shedding, it is very wise to add oral antiviral also.
So the consensus is minor oral steroids plus minus, erythema multiforme major, a short course of oral steroids, yes. And antiviral, you may add it because it is a safe drug, and that is one of the most common causes as far as the infective etiology is concerned. I think that is the conclusion of this particular thing. And COVID related vaccination and COVID per se has not shown any erythema multiforme. As far as the current panelists are concerned, they have not seen any patients who came with erythema multiforme. So that is what is another thing that patients want to know, because every time this, right now when patient is coming, he wants to know whether the rash that he has is because of COVID or because of the vaccine. And that is the way they want to escape from the vaccine. So it should be very clear that the vaccination should continue because it is not causing any major problems, right?
Yes.
So I think, Ritu, are there any more questions to Dr. Sudhakar Gandhi?
No, ma'am, there are no more.
So should we go ahead with the
Yes,
next
yes.
speaker?
We'll go ahead with the next presentation by Dr. Vijay Desai. Dr. Vijay Desai is the first year resident from KEM Hospital, Pune. He will be presenting a case. He passed out his MBBS from MP Shah Government Medical College, Jamnagar, Gujarat, and his area of interest is dermatohistopathology. You may start, Dr. Vijay.
जी मैम. Hello. Am I audible?
Yes, Dr. Vijay. Yes.
Good evening, good morning, everyone. Myself, Dr. Vijay Desai, first year resident doctor, presenting two interesting cases today. So, my first case is 39-year-old female patient came with the complaint of painful lesions in oral cavity since 7 days and skin lesions with itching over both the palms since 5 days. Patient was apparently asymptomatic 7 days back when she developed the painful lesions in the oral cavity. On the second day, she developed the itchy lesions on both the palms, and the lesions were restricted to palms only. Past history, there was a history of the similar lesions in the past in the oral cavity. Patient had a recurrent herpes simplex virus infection, and every time lesions in the oral cavity were followed by the lesions on the palms, and they were very few in the numbers and self-limiting. Family history was not significant. Patient was a mixed diet, disturbed the sleep due to the pain and the normal appetite, but patient was unable to eat because of the oral lesions. General examination and systemic examination were within the normal limits. So in dermatological examination, we can see a single ulcer of 2 by 1 centimeter size with a grayish white surface and surrounding erythema present on the mucosal side of a lip. In the second photograph, we can see the two discrete erythematous ulcers present over right buccal mucosa. Multiple raised lesions, atypical and typical target lesions with the central dusky dark papule surrounded by the pale halo and outer erythematous ring present over bilateral palms. We can see the typical target lesions in the photograph with the 3 zones. So on basis of history and a clinical examination, the provisional diagnosis of erythema multiforme minor as the patient had a history of recurrent herpes simplex virus infection was made. So we did some hematological and biochemical investigations, and the herpes simplex virus 1 and 2 IgG was positive. So my final diagnosis of herpes associated erythema multiforme minor was confirmed on the basis of the following points. There was a raised typical and a few atypical target lesions. The lesions were mainly on the acral regions, and the herpes simplex virus 1 and 2 IgG was positive, and there was no mucosal involvement in this patient. Treatment started in form of tablet valacyclovir 500 mg twice a day for 5 days, tablet Visolon 10 mg twice a day for 10 days, Momet cream for the lesions present on the palm, and acivir cream for the oral lesions. So patient came for the follow-up after 10 days, and at the follow-up she was completely normal. Oral lesions healed completely, and only the PIH was there on the palms. So these are the pre and post treatment pictures of patient. We can see completely healed oral lesions, no active lesions in the oral cavity, and only the PIH was there at the time of follow-up on both the palms. So let's start with my second case. Case number 2. 15-year-old male patient came with the complaint of fluid-filled skin lesions with the itching and burning over the palms, upper extremities, face, trunk, and the lower extremities since 7 days. There was a history of fever since 1 day. There was a history of trauma to the left arm 15 days back, for which patient took a treatment in a form of tablet amoxiclav, capsule omeprazole, tablet domperidone, tablet aceclofenac, and tablet paracetamol. On the 8th day of his treatment, patient developed a fluid-filled skin lesions. They're starting from the palms and gradually spreading over the extremities, upper extremities, face, trunk, and the lower extremities. So patient consulted a private practitioner and then referred to the KEM hospital for further management. Mixed diet disturbed the sleep due to the pain and normal appetite, but the patient was unable to eat because of oral lesions. No history of the similar lesions in the past. Family history was not significant. Patient had a tachycardia and a low-grade fever at the time of admission. Other vitals were within the normal limits. Systemic examination was normal. In dermatological examination, we can see multiple well-defined tense vesicles on the erythematous base with a clear fluid present over bilateral upper limbs, trunk, face, lips, and bilateral lower limbs. Oral mucosa was involved, swollen lips with the crusting and a few intact vesicles. Tongue was covered with a whitish plaque. Conjunctival congestion was there. The genital mucosa was also involved. Few vesicles and erosions were present over the scrotal skin. Few atypical and typical target lesions present with the central dusky vesicle surrounded by a pale halo and the outer erythematous ring on the palms and soles. No lesions were on the nails and scalp. So on the basis of history and clinical examination, our provisional diagnosis was erythema multiforme major. We did hematological and biochemical investigations. Total counts were normal in common blood count, and HSV, IgG, IgM was negative. CRP was mildly raised. So we did a biopsy and a 2 to 5 mm punch biopsy from the vesicular lesion. And histopathological examination showed a marked hyperkeratosis, vacuolization of keratinocytes, area of the keratinocyte necrosis with infiltration by polymorphs and mononuclear cells. In dermis, there was a dense perivascular mononuclear cell infiltration. So the diagnosis of erythema multiforme major, which was drug-induced, made on confirmed on basis of following points. There was involvement of oral mucosa and genital mucosa. There was a raised typical and atypical target lesions and the history of drugs. So treatment started in form of IV fluids, injection acyclovir 400 mg thrice a day, injection linezolid 300 mg twice a day, injection dexamethasone 2 mg twice a day, tablet fluconazole 200 mg, syrup paracetamol as patient had a fever for first 2 days, antacid, clotrimazole mouthpin, chlorhexidine gargles, and fusidic acid plus hydrocortisone cream twice a day for genitalis. These are some photographs of the patient, pre and the post-treatment photographs. We can see the vesicles are reducing in size and no active lesions present. Post-treatment, there were no any active lesions on the lips and the vesicles were disappeared. The histopathological findings of EM and toxic epidermal necrolysis. In a epidermal necrolysis is much more pronounced in a toxic epidermal necrolysis, while dermal inflammation is much more pronounced in erythema multiforme. So the dermal silence in the toxic epidermal necrolysis. You can see dermal silence in a 10. This is a table shows the comparison between the drug-induced IEM and the viral-induced IEM. Drug-induced IEM, these are some examples of the drugs can cause a drug-induced erythema multiforme. And mainly the herpes simplex virus 1 and 2 is known to cause viral-induced IEM. Face and acral extremities are most commonly involved in drug-induced IEM, while acral extremities are most commonly involved in viral-induced IEM. The lesions are polymorphic, target lesions are uncommon, and vesiculobullous lesions may be present in drug-induced IEM. In viral-induced IEM, lesions are polymorphic and target lesions common. Constitutional symptoms are mostly present and may be severe in drug-induced IEM, while in viral-induced IEM, constitutional symptoms may be mild or absent. The course of illness is acute and self-limiting in the drug-induced IEM. In a viral-induced IEM, it is acute. It may be acute, self-limiting, and follows an episode of clinical herpes. It may have a recurrences even without a clinically evident episode of preceding viral infection. The histopathological findings of drug-induced DIM shows keratinocyte necrosis mainly in the acrosyringeal region. The dermal edema is less severe. Perivascular lymphohistiocytic infiltrates mainly of the CD8 plus lymphocytes. In viral-induced DIM, dermal edema is severe and perivascular lymphohistiocytic infiltration mainly of the CD8, CD4 plus lymphocyte. PCR will be positive for the herpes DNA in viral induced DIM, and positive immunohistochemistry for TNF alpha for the drug induced DIM, and for interferon gamma for the viral induced DIM. So I conclude here. Thank you, everyone.
Thank you, Dr. Desai. I don't think we have any questions for Dr. Desai.
And I think Dr. Desai's presentation has made it clear. There was a question regarding the morphology lesions in drug-induced versus viral erythema multiforme. So his table was quite self-explanatory, and there are two types of lesions that you will get in erythema multiforme. One is typical target, atypical target, that is the raised lesions, and second type of lesions would be vesicular lesions. So if it is a drug-induced one, you may see more of vesicular lesions, as you saw in the second case here. And if it is a viral induced, the target lesions would be more common. So that is how you should suspect whether it could be a drug-induced or a viral etiology. And of course, the history of recurrent herpes simplex would give you a clue towards viral infection, right?
There's another question that says choice of antibiotics in erythema multiforme minor and major, which has already been covered. In minor, we've said that azithromycin, and in major, linezolid.
Yeah. And one more thing, Dr. Vijay, I want you to answer about the care of oral mucosa and the genital mucosa, because these are two important things, and of course ocular, if at all any, because this is very important, because sometimes in a busy practice, if you are managing these patients on OPD basis, you may not look at the genital mucosal area, and then if you don't instruct the patient properly on day one, they can land up into a tight phimosis and a stricture. So to avoid that, you have to be careful. And Dr. Vijay, can you tell what instructions you gave to this patient?
Ji ma'am, we can we can advise the patient to regularly exercise the retraction of prepuce skin to prevent the phimosis and the synechial formation, and the good oral care in form of chlorhexidine mouth gargles and the topical steroids for the penile lesions.
Yeah, and while cleaning the mouth, instead of going the brushing of the teeth, like instead of using a hard brush, you should do it with your finger, and you can wrap a gauze around it and clean your buccal mucosa, as well as the sulcus, because there the food particles accumulate, and that leads to the superadded candida infection. So mucosal care in erythema multiforme major is of utmost importance, and we must pay attention to, especially to the genital mucosa.
Yes, ma'am.
Yeah. So are there any questions for him, Dr. Ritu?
No, ma'am. No further questions. We can move on to the next presentation by Dr. Bhushan Matke. Dr. Bhushan Matke is the professor and head of the department, JNMC and AVBR Hospital, Savangi, Barda. He has published more than 102 papers in various national and international journals, 4 chapters in various books, and has special interest in dermatopathology, clinical photography, teledermatology, platelet biology, and its applications. So we'll be talking on SJS TEN spectrum. Over to you, sir.
Is my screen visible, ma'am? Good day, ma'am.
Yes.
Okay. Good morning, everyone, and thank you for providing me this opportunity of a very important and very rare topic to deal with, that is SJN and SJS and TEN spectrum. So SJS-10 spectrum is a type of scar. We call it scar, severe cutaneous adverse drug reaction. And it is very important that today's a very benign looking maculopapular rash with some sore throat and fever could be tomorrow's severe cutaneous adverse drug reaction. And if untreated and undiagnosed, these rashes can be very potentially fatal also to the patient. So what actually happens in the SJS-10 spectrum is the extensive keratinocyte death, so-called apoptosis, which is mediated by CD8 cells. And this apoptosis or keratinocyte death happens in a sheet form, like multiple sheets of the body or multiple areas of the skin surface. They undergo apoptosis and keratinocyte death. And the central cell or the central cell which is responsible for this is the cytotoxic CD8 cells. And these cytotoxic CD8 cells, they though the number of these cells are very less in the dermal infiltrate, but they inflict the damage on the keratinocytes via some soluble mediators. So though the cells may be less, but the soluble mediators may be very high in amount, and they do the keratinocyte death via these two pathways, so-called fast and fast ligand pathway, and another pathway is perforin granzyme granulizing pathway. And all these both these two pathways, they ultimately culminate on the activation of this caspase system, which leads to apoptotic death of the keratinocyte cell. So here is a brief overview of what happens is, now we can see here that the keratinocytes are a very good EPCs. They are antigen presenting cells. So they recognize the foreign body, they process it, and then they present it to the CD8 cells. And then these CD8 cells go to the regional lymph nodes, and then they bind to the dendritic cells in the from the dermis. They go to the regional lymph nodes, and from then we have an influx of this so-called drug-specific CD8 cells. And then this drug-specific CD8 cells, what they do is they release this fast ligand, which goes and bind. I will show you later. And another pathway is so-called the perforin granulism pathway. So there are two pathways. Let us focus on this fast ligand pathway. What happens normally is two cells have this death. One of the cells has death receptors, so-called as FAS, which are like expressed extracellularly, and another is the fast ligand, which is located intracellularly. So during normal homeostasis or normal healthy skin, they don't get chance to like bind each other, this fast and fast ligand. Now what happens is when this two comes together or they bind each other, then this death signaling starts. So normally fast is intracellular, as such fast ligand is intracellular, fast is that is the death receptor is extracellular, so there is no attachment, no death signal. What happens in toxic epidermal necrolysis is the fast ligand becomes extracellular, then there is a ligand receptor complex and the signaling starts, and then there is a death signaling. So this is how. Now an important twist is that this fast ligand, it is released in a soluble form by the CD8 cells. So this fast ligand from the serum, from the blood, will go and bind to the fast death receptor on the keratinocyte. So there will be lot amount of fast ligand which is released by CD8 cells. And this is the target for IVIG, intravenous immunoglobulin. This high dose of IVIG, basically this blocks the interaction between the fast and the fast ligand. That is how we prevent the further apoptosis or the keratinocyte death. And then another pathway is what we call as the cytotoxic CD8 cells. They release fast ligand. Similarly, the cytotoxic T cells also release granzyme B and perforin. What does this perforin do? This perforin go and punches a hole. The 16 nanometer channels are created by perforin, and through these channels, this granzyme B goes inside the cell, that is inside the keratinocytes, and then this granzyme B also leads to activation of caspase pathway. So both fast ligand pathway and perforin granzyme pathway, they go and activate this enzymatic cascade leading to the cell death. Now, recently in 2020, there is a new pathway, third pathway, which is a diagnostic and the severity marker for SJS and TEN has been proposed. And this cells which undergo this apoptosis, they release so-called as receptor interacting kinase 3, RIP3. So elevated serum RIP3 levels in SJS and TEN is associated with the amount of necrotic changes in the epidermis. So more is the amount of necrotic changes. So this like a we can say a laboratory marker, how much is the keratinocyte death, that necrotic keratinocytes will release this receptor interacting kinase, so called as the RIP3 molecule or a RIP3 pathway. Now, let us come to the clinical features pointing to SJS10 spectrum. The rashes are very painful, erythematous rash. There could be bullae, erosions, or typical target-like lesions. In contrast to erythema multiforme, we see typical three-zone target lesions, and the lesions or the areas are positive for Nikolsky sign. Mucosal involvement is very severe. Two or more mucosal area may be involved, and the initial presentation could be like a viral illness, malaise, fever, URI-like symptoms precede the skin rash by a few days. So majority of these patients, they go to a physician or a general practitioners because it simulates like any common flu, but later on it comes into frank SJS10. And lesional skin is quite tender to touch, and minimal shearing forces just by like lying on a bed or by bathing also the skin becomes easily shed off or it peels. So prominent palm and sole involvement. So these are a typical lesion, and there are confluence of the lesion. In erythema multiforme, we see individual discrete lesions, but here on the palms and sole, we can see how they are like coming together and confluence of their. Then there is blistering also on the soles. It is quite see because of the thick skin, it is not showing erosions, but blistering purpuric macules are quite prominent. Scattered and discrete lesions are there. Sometimes it may be very closely, such type of lesions may be very closely simulating like erythema multiforme major, but here the extent of the extension involvement area is quite large. So these lesions could be scattered lesions and discrete lesions. Diffuse erythema with purpura could be there, purpuric macules, purpuric foci may be there when there is a diffuse erythema, and this diffuse erythema may ultimately go into frank epidermal necrolysis if it is not treated very early. So this is the stage where if drugs are given like cyclosporine, IVIG, we may prevent further epidermal necrolysis. Then there is very easy shearing of the skin, especially on the friction prone areas or trauma prone areas, or which areas which undergo a lot of friction. So there is very easy peeling of skin. Blistering is there. Blistering may be very severe in such cases. And whenever there are some blisters, we have to drain those blisters. Otherwise, what will happen ultimately, they will shear off. This epidermal roof will get shear off. Then there is epidermal loss. This is very common scenario in OPD, IPD patients, admitted patients. So whole back is all like exposed, and there is so much of epidermal loss, and it is like an acute skin failure for the patient. Then oral cavity and mucosal sloughing, crusting, hemorrhagic crusting, erosions, maybe till posterior pharynx, all mucosa, buccal mucosa. So the nutrition is quite affected. Intake of fluid and solid food and liquids is very badly affected by this. Then eye involvement could be there, and it leads to very purulent keratoconjunctivitis type of clinical picture. And whenever there are two raw surfaces, if there are two raw surfaces, bulbar conjunctiva and palpebral conjunctiva, and then they heal with fibrosis, it may lead to synechiae formation and difficulty in eye movement also. So what is the histology? This is the posse immune type of, as the previous speaker said, that there is a dermal silence in toxic epidermal necrolysis. So the inflammation is very less, but the amount of soluble mediators which are released is very important further in the pathogenesis of SJS and TEN. And these soluble mediators cause multiple apoptotic keratinocytes throughout the full thickness of the epidermis, and subepidermal split is usually seen. So here we can see a subepidermal split along with necrotic keratinocytes. And very interestingly, the stratum corneum remains very normal. Stratum corneum is hardly affected. It is mainly the stratum spinosum which is badly affected in this process. So this is called as acute stratum corneum. Stratum corneum doesn't get any chance to react to the assault by the CD8 cells. These are some clinical photographs from our patient where we can see, and in previous photographs where it was very exudative type of clinical picture, here we can see the dry dermis. So there is not lot of exudate coming from this. So sometimes it may be dry type of SJS and TEN, and sometimes it may be very wet type of SJS and TEN. Here also epidermal peeling, so almost like a burnt like appearance. Very badly affected oral mucosa, eyelids. This is more in favor of SJS or maybe an SJS 10 overlap could be there. Now, another important thing is how to predict the mortality in such patient. So-called, this is the severity of illness score for 10. This is called as score 10, and it needs to be assessed within 24 hours of admission and again on the day 3. And there are 7 independent risk factors which you have to consider in a case of SJS and TEN. These are age over 40 years, heart rate more than 120, presence of cancer or hematologic malignancies, epidermal detachment, that is more than 10% BSA, blood urine nitrogen more than 28, blood glucose level more than 252 milligram per deciliter, and bicarbonate level less than 20 milliequivalent per liter. Though they say they are independent risk factors, but the major risk factor is number 4, that is the epidermal detachment of the body surface area. If it is more than 10% body surface area, your blood urine nitrogen may go up because of the increased transepidermal water loss or insensible water loss, hypovolemia. So this may be there. So bicarbonate, all this acid-base imbalance happens because of the fluid loss. So this fourth one is the main factor which we have to take into consideration. Now, there is a dictum that any drug can cause any reaction. But however, the clinical experience, vast clinical experience has suggested that there are few categories of the drugs which have highest risk of SJS and TEN, that is nevirapine, lamotrigine, anti-epileptic drug like carbamazepine, phenytoin, Septran, that is cotrimoxazole, and other anti-infective sulfonamide, sulfa group of drugs, sulfasalazine, again a sulfa group of drug, and NSAIDs and oxycodone derivatives of the NSAIDs, and finally allopurinol. Allopurinol majority of the time causes a so-called drug hypersensitivity syndrome or a DRESS type of reaction rather than an SJS and TEN. But there are few cases also. Now, another this interesting area of what we can say in the pharmacogenomics and pathogenesis of SJS and TEN. Now there is a increasing evidence that the genetic factors play a role in causation of SJS and TEN. Certain HLA associations carry a high risk. Like if I carry some particular allele of an HLA, I may be more predisposed to SJS and TEN if I consume that drug. So what are these HLA molecules? These are called as human leukocyte antigen or major histocompatibility complex. These are basically used in transplant medicine. So there are two types called as class 1 and class 2 antigen. Class 1 are A, B, C, they are the locus, and class 2 is the D locus. And there is a rule of 8, like class 1 MHC antigens are CD8 restricted, and class 2 MHC antigen are CD4 restricted. So 8 into 1 is 8, 4 into 2 is 8. So this is a rule of 8. How is this MHC restriction actually happens? So this class 1 antigens are located on all nucleated cells, and class 2 antigens are located on the what we call as the antigen presenting cells. So this plays a very important role in adaptive immunity. Now there are some HLA associations which are noticed with various drugs like carbamazepine, HLA-B 1502 allele, allopurinol, HLA-B 5801 allele, abacavir, HLA-B 5701 allele, and phenytoin, that is HLA-B 1502 and CYP2C9 genotype. However, there is a small caveat that this pharmacogenomics are very dependent or particular to a particular population and ethnicity. Like this carbamazepine HLA-B1502 allele was located in the Han ancestry of Chinese population. So we cannot extrapolate this to Indian population. We need region specific or population specific studies to what is the HLA association. Now many like Japanese, they prefer this HLA-B1502 allele testing, like we do TPMT testing before prescribing azathioprine. Similarly, the Japanese Society for this adverse drug reaction, they say that it is mandatory to do this HLA-B1502 allele testing before prescribing carbamazepine to any patient. Now, many patients are on polypharmacy, like if it's a 40 plus or a 50 plus patient, is receiving antihypertensive, anti-diabetic, and if there is an intermittent any viral illness or a bacterial infection, he receives some sort of antibiotics for 5 or 7 days, and that this may be difficult for a physician in a busy practice to know what is the which drug is leading to this SJS and TEN. So this causation analysis is very important, because this causation analysis will allow us to prepare a drug allergy card for the patient, and we have to find out the very most possible drug which is leading to this SJS and TEN. And this probability scale is called as the Naranjo scale, and it consists of 10 questions which are either answered yes, no, or don't know. This is the link where you can find this Naranjo scale. It is given very nicely. I request all the viewers and the listeners to go through these scales. This is freely available on PubMed portal. So these are the questionnaire where the physician has to tick mark and all this, and then there will be a final score. So depending upon the final score, if the total score is more than 9, we can say that definitive there is a causation analysis or the temporal association between the drug exposure and the SJS-10. Then there is a score of 5 to 8. We can say, sorry. Then we can say it is a probable association, and the score is more than score is about 1 or 4. It is a possible association. So we have to be in this definite criteria. We should try to be in this definite, or the score should try to come in the 9, so that we may be able to know what is the drug. Then score less than 0 is self-explanatory that the drug is not the likely etiology for SJS-10. No re-challenge with a causative drug should be done to find out the definitive drug. So this is an like a unsaid dictum, because it is unethical to again expose the patient after his SJS-10 is better, and then again exposing the patient to a same drug which is not feasible, and ethically also it is wrong. Coming to the principles of management, another important thing is stop the offending drug, which is quite logical. Detail history for the temporal association, we can take help of the Naranjo scale. Skin care, very, very, very crucial. Fluid therapy, very important, because you don't want to drown the patient in fluid. Antibiotic prophylaxis. Now, this is a very tricky issue. Antibiotics, many physicians they shy away from giving IV antibiotics, because they suspect that again the SJS-10 may get aggravated. So it is very important when to use antibiotic. Oral care and genital care or mucosal care are also important. Then there are 5B care, which I will deal with it later on. So this is the overall flow chart, how to manage the overall patient. If there is a patient suspected with SJS-10, refer to a SJS-10, that is a multidisciplinary unit. Unfortunately, in India, we don't have such thing as a multidisciplinary unit. Then assess the severity score by the score 10. Initial investigation, all routine investigation should be done. HIV testing should be done because HIV patients have increased risk of this drug reaction because of immune dysregulation. Then transfer the patient who is experienced in managing such SJS-10. Usually the burn care centers are usually well experienced with this management. Then supportive care, wound management, active intervention. Active intervention means giving either the drugs which will halt the progression of the disease, then continuous assessment, and if the patient becomes all right, then discharge the patient. So all patients need to be ideally managed in a dermatology ICU. Very few centers in India have dermatology ICU, but I think this BLD has one, Dr. Inamdar sir has one ICU setup for dermatology patient. All patients with more than 10% BSA should ideally be admitted in such setup. managed by a skin failure team. This is a like a skin failure is a very broad issue which many diseases or condition lead to skin failure. So it has a dermatologist, nursing staff, ophthalmology, plastic intensivist. They will take care of their own domain. SJS and TEN is a cause for acute skin failure. What does acute skin failure lead to? It leads to thermoregulatory dysfunction, large amount of insensible fluid loss, and hemodynamic instability. Barrier nursing needs to be followed. We don't want that patient should get infected from the healthcare workers or the caretakers. Ambient temperature needs to be raised because of the loss of thermoregulatory function. The patient starts shivering, patient starts feeling cold because he's not able to maintain his core body temperature. Skincare, anti-shear handling of the patient. This is very, very important. We don't want that the patient's skin or epidermis goes on peeling off by rough handling of the patient. So ICU staff and all the ancillary healthcare professionals should be sensitized that skin needs to be cared very, very very carefully so that there is no epidermal peeling. Detached epidermis is to be left in situ because it acts as a biological membrane. It prevents bacterial contamination of the erosions. If there are blisters, aspirate or drain the fluid and allow the roof to settle on the dermis. Bland emollients are to be applied so that there is decreased transepidermal water loss. Soft white paraffin can be applied. Deundated dermis, that is an SJS 10, exudes serum and becomes coated with necrotic debris. And whenever there is any debris or hemorrhagic crust, it acts as a culture for a bacterial growth. So blood is a very good substrate for bacterial growth. Increased skin pain suggests secondary bacterial infection of the erosions. Non-healing erosions should raise suspicion of HSV reactivation, especially around oral cavity and genital areas. Regular skin swab should be sent at a period of 7 to 10 days to know what is the what type of organism it is there on the patient's erosions and what is the sensitivity pattern. Clean intact skin and erosions by irrigation with normal saline. Try to use warm saline because if you use a cold saline, patient may again undergo a shivering response because of the fall in the core body temperature. Prefer a non-adherent dressing. This is a very vast topic. What are the various non-adherent dressing? Usually we use autoclaved banana leaves or molini sheet and liquid paraffin gauze pieces or gauze gowns soaked with liquid paraffin. But these all needs to be sterilized in autoclave before using on the patient. Non-sensitizing topical antibiotics should not be used. Non-sensitizing topical antibiotics should be used. We don't want to that the patient should go under an eczematous response like neomycin and neosporin powder. All these are sensitizing antibiotics. Avoid silver containing products and dressing because the erosions are quite large and the body surface area is quite big. So we don't want then there should be risk of absorption of the silver containing products. Fluid resuscitation, another very, very crucial topic for managing patient with SJS 10. Goal is to prevent end organ hyperperfusion and shock. And over-aggressive fluid resuscitation may lead to pulmonary, cutaneous, intestinal edema. So it is a very, very important topic that fluid management. Unfortunately, we are not well versed with the fluid management. So we have to take a help of a physician or an intensivist who will titrate the fluid therapy. Fluid are usually needed if there is more than 10% BSA epidermal detachment. And how much fluid should be replaced is given by this formula, that is 2 milligram per kg body weight per body percent surface area epidermal detachment. And the target for the fluid therapy should be like the patient should get a urine output of 0.5 to 1 ml per kg per hour should be maintained. And we have to monitor the signs for hypoperfusion and overload. So auscultate the lung, measure urine volume, try to assess the skin turgor, capillary refilling. So all these are subtle signs from clinical medicine which we should adopt to know what is the fluid status of the patient. If patient is having a central line, then the central line monitoring will very much tell us about the overall fluid status of the patient. Pain control, mild pain is there, we can use paracetamol. Moderate to severe pain, opioid-based analgesia. However, opioid-based analgesia has its own drawback. The level of consciousness may drop, respiratory rate may drop, and oxygen saturation may drop. So opioid analgesias needs to be very judiciously used if there is very severe pain. So acetaminophen can be used. Aspirin needs to be avoided because we don't want that the gastric injury should occur and then there is a GI bleed happening in the patient. Nutritional support, another very important crucial topic. We have this SJS-10 is a hypermetabolic state. There is loss of protein from the exudate, and the patient is unable to eat proper food. So patient is going under a catabolic state. So in the early phase, we need 20 to 25 kilocalorie per kg per day in the early phase of the disease, and in the recovery phase, we have to give 25 to 30 kilocalorie per kg per day, ideally through a nasogastric feed. And if patient has less oral involvement, then we may promote oral feed also. When to use antibiotics in a patient with SJS-10, another important count. High bacterial count is there, like a single strain from the culture, either from a skin or a catheter sample of a urine. Patient is having hypothermia. Patient was stable and then suddenly he has gone into hypothermia. There is a confused mental state, anxiety, excitement, delirium. That is another soft indicator for using parenteral antibiotic. Then there are symptoms of infection, particularly to a particular organ system, pneumonia, urinary tract. So all these organs need to be looked for and cared for also. Active intervention. Now what do you mean by active intervention? As of now, only there are 3 or 4 drugs which will halt the progression of the disease. These are IVIG, systemic corticosteroids, and cyclosporine. What does IVIG do? In high concentration, normal immunoglobulin inhibits the FAS and FAS ligand interaction, which we have seen in previous slide, and apoptosis through anti-FAS activity. So it doesn't allow the interaction of FAS and FAS ligand. High doses used, normally we use 2 gram per kg in many connective tissue disease or Kawasaki syndrome, Kawasaki disease, but here it is around 2.8 to 4 gram per kg over a period of, divided over a period of 3 to 5 days. So this is a high dose IVIG. Systemic corticosteroids, there are now 2 school of thoughts. Like if you give high dose corticosteroids early in the therapy, it leads to decrease in the inflammation, helps in controlling the inflammation. However, on the downside, high dose corticosteroid may increase the risk of sepsis also. So there are 2 school of thoughts. Personally, I don't prefer systemic corticosteroids in such patients. Dexamethasone and methylprednisolone are the preferred agents. For methylprednisolone, either 500 milligram or 1000 milligram per day for 3 days is can be given. Cyclosporine, wonderful drug. It inhibits T lymphocyte activation. We know that T lymphocyte activation is the main cell or the main inflammatory response which happens in SJS and TEN. Short course of cyclosporine, that is like 3 to 5 milligram per kg per day for a period of 7 to 10 days is fair enough course. Significantly enhanced speed of reepithelialization and reduced hospital stays noticed. And if patient is hypertensive, because that is a main concern, cyclosporine can be given under a cover of calcium channel blocker. So don't hesitate in giving cyclosporine even if the patient is hypertensive. Anti-TNF agents, thalidomide was used, but it was noticed that thalidomide has more mortality when it was used in patient was SJS-10, and it has fall out of repute. Now, single interim subcutaneous injection of 50 milligram of etanercept is advocated, and the median time of epithelial healing was around 8.5 days. So, which is a good agent. However, it is costly. In non-ambulatory patients who are bedridden, old age, not able to get up, we have to take care of base of the lung, we have to take care of bladder, we have to take care of bowel, we have to take care of bed sores, and we have to boost the morale of the patient in these patients. Thank you very much.
Thank you, sir, for an excellent and a crisp, detailed, in-depth account on SJS and TEN. We'll take up the questions now.
Yes, ma'am. Can I exit this now? Stop sharing?
Yes, you can stop sharing. Yeah. We'll just discuss the questions.
Excellent presentation, Dr. Bhushan.
Thank you, ma'am.
Yeah. So I just wanted to know your preferred choice in 10 patient, like
cyclosporine, ma'am. Cyclosporine.
First line.
Yeah.
And
yeah,
how
cyclosporine.
IVIG?
IVIG we have used in few patients where there was renal failure in a patient, and there we use IVIG for the patient, and he also responded well. But the first line is cyclosporine in current scenario. Yeah.
And cyclosporine alone is enough in most of the cases. That is what is
yes, ma'am.
Yes.
A day, 2 or 3 short course of steroid to control the initial inflammation along with oral cyclosporine or a suspension type of cyclosporine is fair enough. But I don't give more than 3 days of oral or parenteral steroids in such patient, parenteral steroids.
Yes.
Is there a
Cyclosporine
difference?
can be given to 7 to 10 days around time.
Is there a difference in efficacy of cyclosporine in children and in adults?
Children's, very fortunately, very less cases I have seen. They are more in adults I have seen, but pediatrician prefer IVIG. I have noticed that even if I say them give cyclosporine, they don't prefer cyclosporine in my institute or in my area. They prefer IVIG, and yes, they have come out well also. So IVIG I think is more preferable. They in pediatric age group, and cyclosporine because the dose needed is in pediatric age group. However, the dose may be more in adult, like the total dose of IVIG in adults is more. So it is a costly treatment.
And is it anything to do with the renal system in pediatric age group, or maybe the renal?
Yeah, ma'am, it is safe. It is safe, quite safe, because we use cyclosporine in lichen planus also in pediatric age group also for a short duration to control the, if there's a eruptive LP, and our experience is quite now good that cyclosporine is a safe drug with good monitoring. In fact, in LP we give say around 6 to 8 weeks, but in SJS10 we need to give only for a very short duration around 15 days, 10 to 15 days.
Yeah. And in pediatric age group also the same 5 mg per kg, or you should be good with 3 mg per kg of
Yeah, 3 to 4 is a good range.
dose.
Yeah, 3 to 4 is a good range. Many times, if there is, like say we start with 3 milligram and we don't expect a response, we are not seeing a response, we can always titrate the dose.
Yes.
We can up dosing, we can do.
Have you anytime come across patients where your cyclosporine had failed, like, or maybe you did not get a desired response and you have to use something like TNF alpha blockers in these patients?
No, ma'am. Fortunately, till date, I am yet to come across a case that patient have not responded to cyclosporine. Fortunately, not yet experienced this.
And about cyclosporine, it is actually said that it gives best results when you start it in first 24 to 48 hours. But many times
for any drug. For
yeah,
any drug, ma'am, because
yeah,
we want to hold the whatever is happening at the cellular level. So
yes,
you hit early, hit hard, so the disease progression will not happen.
yeah, but sometimes the patient by the time comes to a dermatologist, it is almost 7-8 days have already passed without cyclosporine. So in
Correct,
that
correct.
case also, do you add cyclosporine, or you
Yes,
have a
ma'am.
different strategy? So
Yeah, ma'am.
anytime the patient comes, it has to be given, whether it is in first 48 hours,
yeah.
first week, anytime.
First 48 hours, or say maybe he's presenting late at 5 or 7 days also, and we see that there is active inflammation, signs of active inflammation, blistering is there, purpura is there. It is better to add the drug because we know that disease activity is still going on, so there is some target for cyclosporine.
Yes. And the patients who have less than 10% body surface area detachment, SJS group, like not towards the spectrum,
Yeah, yeah.
is the line of management same in all three, like the less than 10, 10 to 30 and 30% and above?
Mostly the SJS10 and the 10 cyclosporine is preferred, and
yes,
in SJS we usually active non-intervention, like we keep a close watch on the patient and see whether he is progressive or decreasing. A lesion count is very important in patient having less than 10% BSA. A lesion count, we ask the patient how many lesions he is getting nowadays, so that will help us to assess the severity and the progression of the condition and how is he feeling overall.
yeah, so maybe cutaneous tenderness, confluence, and appearance of new
Yes.
lesions would be the indicator for adding
Correct.
cyclosporine,
Correct.
or otherwise only oral steroids in a little.
Yeah, many time 2 or 3 crops come and then the disease halts at that stage, and but sometimes it may progress also. So like it's a tailor-made equation for each patient.
Yes. So, are there any more questions?
No, ma'am. No, ma'am. There are no more questions. So I think we'll move
I think
on.
Dr. Vinay Kulkarni has asked one question. Is there, if there is activity going on, use of cyclosporine versus steroids? If the disease is active.
Hmm.
What will you prefer between cyclosporine and steroids? That is what he wants.
Cyclosporine, ma'am. Because the steroid dose needs to be very high in SJS and TEN, and there is always an overwhelming risk of secondary inpatient sepsis. And so steroids, like being a pan immune suppressant, it is preferable to avoid as far as possible.
And between Dexa and methylprednisolone, which is a better one as far as the use in 10 patients is concerned? Is
As
there
such, there are no
positive or negative between the two, or maybe the
dexamethasone. I prefer dexamethasone, injectable intramuscular dexamethasone, rather than for a pulse methylprednisolone. I prefer divided dose of dexamethasone.
So is it something like the elimination time of these two is different? Is it shorter?
The depend on the acting. The dexamethasone is a long acting one, and less amount of mineral corticoid action, more glucocorticoid action. Methylprednisolone do have some electrolyte and cardiac changes also, which happens with methylprednisolone. So I prefer dexamethasone. It's my personal choice.
So you said you give IM intramuscular or IV?
Yeah.
Dexa.
I am. If it is either way is fine, ma'am. I am also and IV also. But when there is an IV line, we prefer IV.
And how do you decide the antibiotic cover that you need to give?
Ma'am, usually antibiotic is a very tricky issue. IV, I think parental azithromycin, parental doxycycline, these are available. So these can be used for the initial cover, but later on the blood culture and the skin culture suggests what antibiotic needs to be added. So majority of the time, these drugs which are leading to SJS, and these are mainly of the anti-epileptic class of the drugs. Hardly any antibiotics, very rare to see an antibiotic like a sulfonamide, sulfa group, and these are not given parenterally also. These closely chemical related drugs, like if there is a patient with sulfonamide, there is no sulfa counter in a parental form. So like azithromycin, parental doxycycline are safe in such patient.
Even linezolid.
Yes, linezolid, vancomycin are also there. So the cross reactivity issue hardly comes up when if it is because of anti-epileptics.
Cross reactivity is, I think, mainly with amoxiclav and cephalosporin.
Cephalosporin.
Right?
Correct. So there are alternatives available when we have to give parental antibiotics. Many alternatives available.
All right. So I think
we are done with the questions for Dr. Bhushan, right, Ritu?
Yes, ma'am. So thanks a lot once again, Dr. Bhushan.
Yeah.
Now we'll move on to the next. Sorry.
Yeah. Go ahead.
Now we'll move on to the next case presentation by Dr. Kiran Ardar. Dr. Kiran Ardar passed out from KEM Hospital, Pune, and is practicing at Dermacure Clinic, Wakad. Dr. Kiran?
Yes, ma'am. I will share my screen. Is it visible, ma'am?
Yes, you can make it full screen.
Yes, ma'am. Thank you, Ritu ma'am, for kind introduction. And good morning, everyone. Today I'm going to present 3 cases. My first case is 55-year-old male came with complaints of increased sensitivity in the oral mucosa with difficulty in swallowing, lesion over palms and soles since 5 days. Lesion progressed to all over body within 3 days. Fever with chills since 2 days.
Kiran?
I'm not able to move my slide, ma'am.
Just click on the PPTs and then you will be, yeah. And then you can.
Yes, okay. There is a history of fever 15 days before the appearance of skin lesion. He took a symptomatic treatment, but there was no relief. The investigations were done on 1st of August, which were normal except for hemoglobin, raised ESR, raised blood sugar levels, and Bill Felix reaction was positive. He took a treatment in the form of capsule doxycycline 100 mg once a day, paracetamol 500 mg twice a day for 7 days. Patient completed course of above medication and then was symptomatically better for next 2 days. After 2 days, patient started experiencing increased sensitivity in the oral cavity, which was associated with difficulty in swallowing. Reddish lesions, initially over palms and soles, then becoming generalized over the period of 4 days. Skin lesions were associated with the fever and chills. So he consulted to a dermatologist and was given a cyclovir, which he took it for 2 days only. Then he got admitted at our institute under the care of physician, and the skin reference was given to confirm whether the rash is rickettsial or Stevens-Johnson syndrome. He is a known case of hypertension since last 10 years on medication and recently diagnosed diabetic. On examination, multiple well-defined purplish macules of varying size present all over the body, and as you can see, macules are coalescing at some places. Skin in between the lesion is normal. Few bullae are present over the thigh, as you can see in the second picture. And the pseudonechosis sign was positive. There were multiple well-defined erythematous macule present over the palms and soles. Mucosae were also involved. There were crusted lesion over the lips, whitish plaque with few erosion present in oral cavity. The penis and scrotum were showing erosions. So we came to our provisional diagnosis as Stevens-Johnson syndrome, may be drug-induced or post-rickettsial. And we investigated our patient, which were showing low hemoglobin, raised CRP, and USG suggestive of hepatosplenomegaly with grade 2 fatty liver. Histopathological examination showed in the epidermis there is a detachment, necrotic keratinocytes, and dermis showing mononuclear cell infiltrate, dilated blood vessels with perivascular mononuclear cell infiltrate, which is suggestive of Stevens-Johnson syndrome. This is an image with red dots showing epidermal detachment in our patient, which is roughly less than 10%, and it corresponds to left figure of the Stevens-Johnson syndrome. This is a table showing difference between rickettsial rash and Stevens-Johnson syndrome. In rickettsia, the rash is of fern leaf pattern, and initially it is a macular, petechial, then forms necrotic eschar. It is mainly distributed in the acral area and spread to the rest of body, usually sparing the face. While in Stevens-Johnson syndrome, the lesions are flat, that is atypical targetoid, and distribution is mainly central with the involvement of at least 2 mucosal sites. The histopathological difference between the two is the rickettsia is mainly showing the vasculitic picture, while in Stevens-Johnson syndrome, in early phase there is a necrotic keratinocytes in the epidermis. Later on, there is a full thickness epidermal necrosis. So we treated our patient with injection dexamethasone 4 mg 8 hourly, and which is then tapered off. IV antibiotics, injectable paracetamol, and cyclosporin capsule 5 mg per kg in divided doses. And we completed the course of doxycycline for 10 days. Tablet levocetirizine, chlorhexidine mouthwash, and chlormycetin applicase for genital lesions. Along with this, paraffin and glycerin over the lips. So to conclude, infections may lead to cutaneous reactions like SJS or TEN in addition to drugs. And right side picture is showing the list of infection which are prone to cause Stevens-Johnson syndrome or toxic epidermal electrolysis. The vaccines of measles and hepatitis B may cause the similar reaction. Now moving on to the next case. A 18-year-old female came to us with a complaints of rash all over the body with mild itching since 7 days, fever on and off, cough since 4 days, difficulty in swallowing since 3 days. She was all right 10 days back when she had a fever, mild to moderate in nature, along with watering of the eyes. So she consulted local doctor for the same and was prescribed amoxicillin and clavulanic acid and multivitamin injection. After 2 days, patient started developing fluid-filled lesions all over the body, including oral and genital mucosa. Skin lesions were associated with fever, and she was admitted in private hospital for 3 days and then referred to our hospital. On dermatological examination, multiple well-defined plaques of varying size with purplish hue present all over the body bilaterally. And there were multiple well-defined bullae containing clear fluid present in the oral cavity, back, chest, genital mucosa. Erosions were present over the lips, cheeks, back, and chest. There was also eye involvement in the form of ectropion and conjunctival congestion. So we came to our provisional diagnosis as Stevens-Johnson syndrome, toxic epidermal necrolysis overlap may be drug induced. We investigated our patient and all investigations were normal except for hemoglobin, and the total protein were decreased. CRP was increased and the chest X-ray showing patchy, ill-defined opacities, which is suggestive of infective etiology. On histopathological examination, epidermis is completely necrotic and shows basket view orthokeratosis, subepidermal bulla with separation of epidermis from the dermis, and bulla containing fibrin, extravasate RBCs, and eosinophils. So our final diagnosis was Stevens-Johnson syndrome, toxic epidermal necrolysis overlap. And as you can see in the right-sided picture, the red area is showing epidermal detachment in our patient, which is almost equivalent to 25%. And it corresponds to the middle figure of the left side, that is of SJS-10 overlap. We treated our patient. First of all, we stopped the culprit drug, that is amoxicillin, and then started with injection dexamethasone, and it was rapidly tapered off. And IV antibiotic, we preferred injection linezolid and IV albumin, along with IV fluids and capsule cyclosporin 150 mg in divided doses, and antihistaminics and liquid paraffin dressing. To prevent cicatrization, the eye care in the form of rod sweeping, emollient eye drops, tobramycin eye drops, oral care in the form of chlorhexidine mouthwash, and antifungal mouth paint, gargling after every meal was given. RT feed to prevent esophageal stricture and sucralfate syrup was added. These are the pre and post treatment photographs of the same patient. The aminopenicillins, as we know, are on the top of list of drugs causing cutaneous reactions along with the other drug listed below. My third case is 35-year-old female complaining of fever with rash all over the body, swelling of the face, as you can see in the first picture, and difficulty in opening the eyes, difficulty in swallowing since 3 days. She had a history of tinea cruris and she took itraconazole and griseofulvin for 2 weeks. Rash appeared on the 15th day with fever and chills. She was not having any comorbidity. On day 1, discrete maculopapular lesion present over the acral region. In between skin was normal, and there was no mucosal involvement. Along with this, Sido-Nikolsky sign was also negative. Lesions within 2 days become confluent and generalized. Lips showing hemorrhagic crusting and erosions. Mucosal examination showed there were 2 bullae present over the hard palate with a whitish thrust. Eyelid skin and conjunctiva was also affected, and genitals showing few erosion with yellow crust over the labia majora. The Sido-Nikolsky sign was then positive. The patient was progressing from Stevens-Johnson syndrome to toxic epidermal necrolysis. And our provisional diagnosis was toxic epidermal necrolysis due to maybe itraconazole or griseofulvin. The investigations were normal except for the liver enzymes, which are highly raised, and the urine examination showed presence of protein, pus cells, RBC, and granular cast. On histopathological examination, basket view hyperkeratosis, basal cell vacuolation and separation, extensive keratinocyte necrosis present in the epidermis, and dermis showing mild mononuclear cell infiltrate, which is suggestive of toxic epidermal necrolysis. Then our final diagnosis was toxic epidermal necrolysis, drug-induced. The red dots in the right figure are showing the area of epidermal detachment, which corresponds to the third figure, that is of 10. That is more than 30% body surface area detachment. This is a prognostic scoring system called score 10, which includes the 5 factors, each pointing 1, and more than 5 score predicts the mortality of more than 90%. We treated our patient on the day 1 with IV dexamethasone thrice daily, which was tapered every 3rd day. And later on, we added cyclosporin, oral suspension 5 mg per kg for 2 weeks. Oral antihistaminics and emollient and banana leaf dressing for faster wound healing. In addition, mucosal care, as discussed for earlier case, was also taken, and we also, the ophthalmologists were also added cyclosporin eye drops for this patient. These are the post-treatment photographs. She was recovered very well, except for the conjunctival congestion and photophobia. These are the antifungal drugs causing toxic epidermal necrolysis. Itraconazole, voriconazole, and terbinafir are very common, and comparatively rare are the griseofulvin and fluconazole. So to discuss azoles, that is itraconazole, fluconazole, and ketoconazole, pollens, that is amphotericin B, are known to cause SJS or TEN. Erythema multiforme 10, acute generalized exanthematous pustulosis, is more common with allylamines, that is terbinafine, and griseofulvin is known to cause photosensitivity. This is a histological picture. The clinical correlation is actually essential to distinguish between erythema multiforme, SJS, and TEN, as they may look nearly identical histologically. And we cannot reliably distinguish based on the full thickness epidermal necrosis or necrolysis, because erythema multiforme may have it and SJS 10 may not have, depending on the site of biopsy. Thank you so much, team IADVL Pune, for giving me this opportunity.
Thank you, Dr. Kiran, for the lovely
Should
cases.
I stop sharing, ma'am?
Yes, please. Thank you. I don't think we have any questions, ma'am.
Yeah, only if Dr. Bhushan is still there, there was a question for him regarding the cyclosporin trough levels. Serum cyclosporin levels. Dr. Ramesh Puria is asking this question about serum cyclosporin trough level.
Not needed actually.
Not needed, yeah, because it is a very short course. Like if the patient is all right and you stop it, it's not a long-term cephalosporin that we are looking at when we are treating psoriasis, or maybe it is more for, I think, the transplant patients, not for our dermat patients.
Even for transplant also, they hardly do.
Hardly do, yeah. They do mostly, I think, tacrolimus levels and not
monitoring. This is called as therapeutic drug monitoring. But for cyclosporin, for 7 to 10 days, we don't do it. Just create monitoring is sufficient enough.
Sufficient, yeah.
If one wants.
Yeah. So, Dr. Ritu, I don't think so there are any questions for Dr. Kiran, so you can go ahead with the next presentation.
Right. Moving on to the next presentation, it's by Dr. Vidyadhar Sardesai, sir. He'll be talking on DIH and DIHS. Sir needs no introduction. He's the professor and head of the Department of Dermatology, Venereology and Leprology in Bharati Vidyapeeth Medical College. Sir passed out his MBBS, DNB and MD from BJ Medical College and stood first in the MD exam. He has more than 30 years of teaching experience and is a postgraduate teacher and examiner. He has multiple publications in international and national index journals, and he's a faculty and speaker at various conferences and forums. So special interest is in clinical dermatology. Over to you, sir.
Yeah. Okay, can you see my screen?
Sir.
No,
Not
sir,
yet.
not yet.
Now?
Yes, now,
Yes,
yes.
Yeah.
You can make it full screen.
Yeah.
Yes.
Well, a very good afternoon. To give a talk after the master class by Bhushan, I mean, I'm feeling like a batsman after Sachin Tendulkar. I mean, I hope the audience enjoys this lecture equally, or this thing. So this is a topic which is slightly different, although it is the same as far as the drugs are concerned. It's slightly different from the previous two talks, because here it's going to be more of the organ involvement. It's going to be focusing more on the organ along with the skin, and less of mucosa and so on. So we are going to need help of a physician and in managing these cases. So let's go ahead. What my talk today will be upon is these terminologies, especially the DIH, DIHS, and several other terminologies. And it will be focusing mainly on dress. We'll be seeing some introduction about this condition, the drugs implicated, the etiopathogenesis, which is very important to understand, the clinical features, the diagnosis in which the scoring system is there, the differential diagnosis, and of course the management. So when we say this terminology, drug-induced hypersensitivity, we see it as the various Coombs and gel different types of hypersensitivity reactions, and we have to concentrate on these three. Type 4B hypersensitivity reaction, which gives a maculopapular exanthem with eosinophilia, which you see as in dress. The type 4C, which gives a maculopapular and bullous exanthema, which we see in SJS 10. And the next type, and that is the AGEP, that is the acute generalized xanthomatous pustulosis. So if we try to differentiate these three, what we see essentially in dress is a slow onset and a long duration. This differentiates from the other two type of drug reactions. This is characterized by a very slow onset. It can come even as late as 6 weeks after taking the drug. And secondly is the duration of reaction. It's going to go on for weeks or months sometimes. The facial edema is something which is very characteristic of dress, which differentiates it from the other two type of drug reactions. And Third is the lymphocytic infiltrate, the lymph node enlargement, and the lymphoid hyperplasia. That is another unique feature of this type of reaction. And as I said, compared to the others, of course, there is no doubt some organ involvement in SJS/TEN also, but the organ involvement is very predominantly seen in DRUS. And finally, the eosinophilia and atypical lymphocytes. So these are the characters of this reaction which differ it from AGEP as well as the SJS/TEN. And then if we see the mortality, no doubt 10 has a mortality of about 25 to 35%, but HSS or DRESS has a mortality of 10 to 40%. And if we see the, these are the two different type of drug-induced hypersensitivity reactions where they can become fatal and where we should be worried about, and the care should be utmost. And if we see the list of drugs, well, the anti-epileptics, as always, are the predominant drugs causing these type of reactions. Now let's go to the various terminologies, because there are so many terminologies like DRESS, DHS, HSS, DIHS, and so on. So HSS is nothing but the hypersensitivity syndrome, which was initially this type of reaction was called hypersensitivity syndrome. Then came a terminology of DHS, that is the drug hypersensitivity syndrome. Then came DRESS, and that is the drug reaction with eosinophilia and systemic symptoms. Another terminology which highlights the organ, and that is the DIHS, that is the drug-induced delayed multi-organ hypersensitivity syndrome. So even if you withdraw the drug, the organ involvement, the organ hypersensitivity goes on, and you have to be careful in monitoring these patients. And finally, the SCAR, this terminology is the severe cutaneous adverse reaction. So all these terminologies more or less are synonymous, more or less are slightly different in small aspects, but then you shouldn't get confused with it. Important thing to remember is a drug reaction, hypersensitivity, some blood abnormalities, and the organ involvement. So if we see this drug-induced hypersensitivity syndrome, that is the DIHS, it's the other synonyms, sometimes they are called as DHS, HHS, and DRESS. It's recently, as I said, also referred as DIHS, is increasingly being recognized as a distinct type of adverse drug reaction. And the major offender in all age groups is anticonvulsants. But newer and newer drugs are being recognized as inducers. What is important in DRESS is the long-term sequel. If you see about 12% end up with autoimmune thyroid disease, especially the young patients with DRESS, and in elderly, renal failure is another long-term sequel. And as I told you, the mortality can be from 10 to 40%. So remember this triad: fever, skin rash, and internal organ involvement. And be careful, the internal organ involvement may be symptomatic or even asymptomatic. So that's where our role is. It's really to judge or to diagnose DRESS and to look out for the internal organ involvement as early as possible. So what are the unique features of DRESS compared to the other drug reactions which we saw just now? Number one, as I said, it's a long latent period. Number two, very important, is the less severe mucocutaneous involvement. Just now we saw the care of the mucosal lesions, the oral mucosa, genital mucosa, and so on. Here there will be less mucocutaneous involvement. But third, it's a higher risk of systemic involvement. So you are going to need a physician, no doubt about it. You can't just manage on your own. Fourth, again, very important, paradoxical flare-up on withdrawal of offending drug. So the story doesn't end on just withdrawal of drug. It's going to go on because sometimes even after the drug is withdrawn, there is a paradoxical flare-up. Why it happens, I will explain to you in the further slides. But that's why that adds to the confusion, because normally we are trained, you stop the drug, you tell the patient you stop the drug, and usually the reaction will subside. And fifth, of course, is the requirement of prolonged treatment with systemic steroids to prevent these flare-ups. And last but not the least, the autoimmune manifestations in later life. So if you remember these 6 unique features of DRESS, it's very, very useful for us. Now, there is a cohort of patients which fail to reach the full diagnostic criteria, yet clearly manifest a syndrome more complex than the simple drug exanthem. And then this is called as a mini DRESS. We are always fond of all these different terminologies. Now, let's see what are the drugs implicated in DRESS. So you have, of course, the first associated with the aromatic anti-epileptic drugs. This was associated with aromatic anti-epileptics, and that's the phenytoin, carbamazepine, phenobarbital, lamotrigine, and primidone. But what is of interest for us dermatologists is these drugs which we use so common, like the sulfonamides, dapsone, minocycline, terbinafine, azathioprine, cyclosporine, NSAIDs, and antiretrovirals, especially the nevirapine and abacavir. So these are the drugs which we are using quite often, and so we have to keep it in mind. And then comes the important drug, and that's the allopurinol. And then, of course, other antihypertensives and so on. So these are the drugs which are implicated in DRESS. Now, this tells you that the onset, if you see roughly 2 weeks after the drug intake, it's longer than 2 weeks, especially in cases of aromatic anticonvulsants and allopurinols. Now, these are the ones which commonly cause DRESS. And it is a shorter onset, less than 2 weeks, in cases of beta-lactams, antibiotics, and iodinated contrast media. So although we say it's after a long time, more than 2 to 4 weeks, in some cases it's less than 2 weeks also. What about the etiopathogenesis? Now this is what we should understand to understand DRESS. There are 3 important factors. One is the genetic predisposition, which Bhushan has explained to you very well, the HLA linkages. Second is something already wrong in the drug metabolism by the liver. Since we all, DRESS, the target organ to start with is liver, and there is a defect in drug metabolism by liver, and that's the reason why it goes on worsening. And the third, and nowadays the major role, is the role of a virus. So if you see the genetic predisposition, I think this has already been explained by Bhushan, so I won't go into detail, but there is a HLA linkage for abacavir, there is the HLA linkage for carbamazepine, and then of course allopurinol, as far as SJS/TEN is concerned, also there is an HLA linkage. And the role of virus is, if we see, is the HHV6 reactivation. Now there are 2 schools of thoughts. Number one is that the primary event is a viral reactivation, and that leads to DRESS or DIHS, or more commonly what people think is that role of virus is secondary event in DIHS, and that is the primary reason why this DRESS reaction goes on, lingering on after a long time. So what they say is the activated T cells in DRESS, they reactivate the latent HHV6 genome in the T cells. And certain drugs which cause transient immunosuppression are also responsible for the latent HHV6 reactivation. And that's the reason for the chronic phase of DRESS. So as far as this slide is concerned, the take-home message is remember about the viral reactivation. Remember about the HHV6. As far as the delayed T cell reactivation is concerned, it could be the conventional haptenization theory or the PI concept, that is the pharmacological interaction with the immune receptors. We all are aware of the drug metabolite with protein, that is the hapten carrier inducing the immune response. But the PI concept is that the drugs which lack the hapten, they directly bind to the immune receptors and induce the immune response. And what is the role of reactive metabolites, especially in aromatic anticonvulsants? Now, normally they produce toxic metabolites which are detoxified by glutathione and hydroxylase. But in case there is a genetic or acquired enzyme deficiency, then this step is blocked, and that's why those toxic metabolites can lead to DRESS. Or in case of like lamotrigine, if a high dose is given, or if fast titration done, or given with valproate, these 3 conditions can, situations may precipitate DRESS. Or in allopurinol, if it's given in a patient of chronic renal insufficiency or in a higher dose, that itself can produce DRESS. So this is the role of reactive metabolites. So in short, there are certain drug-related factors, there are certain intercurrent viral infections, concurrent disease, and altered immune response and TH cytokine balance. All these factors together are involved in the pathogenesis. And as I said, the major clinical focus in diagnosis and treatment is drug hypersensitivity reaction, whether it leads to HHV6 reactivation. And why this is thought so? Because the HHV6 DNA is detected in the serum about 3 to 5 weeks after the disease onset. And it is followed by a dramatic rise in anti-HHV6 IgG titers. So that's the reason why it is thought so. And what is the importance of HHV6 reactivation? It will trigger symptom recurrence. So even after you have stopped the drug, the symptoms may recur, and sometimes it may be fatal by causing serious dysfunctions, including the liver failure. So nowadays, the focus is essential to identify factors predictive of virus reactivation, especially several cytokines and chemokines like levels of TNF-alpha and TARC. So they are supposed to be good biomarkers of virus reactivation. And what is the reason for less severe cutaneous involvement in DRESS? Like we saw, mucocutaneous involvement is less severe than SJS/TEN, and that is because of the expansion of the regulatory T cells in acute stage. Now, these regulatory T cells, they suppress the activation of cytotoxic T cells, and that's why you're not going to get that apoptosis and cell death which occur in SJS/TEN. In TEN, what happens? These regulatory T cell migration is suppressed, and that's why the cytotoxic T cells cause the toxicity to the epidermal cells. And what is the causes of multi-organ failure in DRESS? Number one is the superadded bacterial infection. And number two, and very important, is the hemophagocytosis, which is due to the massive immune dysregulation leading to production of interferon gamma and the macrophage colony stimulating factor. There is another very interesting terminologies, and since we are discussing so many terminologies, and that's the VRES, that is a viral reactivation with eosinophilia and systemic symptoms. This is HHV6 reactivation independent of DRESS, but it is seen as a DRESS picture, and that's why it's termed as VRES. Now that's enough of the etiopathogenesis. In short, I mean, whatever I could explain to you, let's come to the clinical features. Now, the common age group is 31 to 57 years, females more than males. It's rare in child and infant. In case it occurs, it's fast and full recovery. So the prognosis is good in younger age. Latency is about 1 week to 3 months. And as I showed you, carbamazepine and allopurinol have a longer latent period. The initial symptom frequently is fever, followed by a rash. And rash is a universal finding. Most common is the maculopapular, diffuse erythematous exfoliative dermatitis type of rash. Starts from the face, upper trunk, progresses to extremities and becomes generalized. What is characteristic is the dermal edema with follicular accentuation leading to infiltrated plaques. And this is very characteristic of DRESS. And there is a marked erythema, edema of the face, and periorbital accentuation, which is a hallmark of DRESS. And of course, other clinical types like urticarial, erythema multiforme, purpuric pustular may occur. So that's about the rash. A rash suggestive of DRESS, 2 out of 4 features should be present. 1 is the facial edema. 2 is the infiltrated lesion. 3rd, purpuric lesions on areas other than legs. And 4th is the rash subsiding with psoriasiform desquamation. So this is the typical facial edema. This is the perioral slightly scaling which has been seen. And this is the maculopapular rash. So here, mind you, there is no erosions, there is no fluid loss, there are no mucosal lesions, which we saw in the previous 2 drug reactions. Mucosal lesions are mild. There may be some chylitis, pharyngeal edema, genital or oral ulcers are rare. Lymphadenopathy is very important. It's localized or generalized, and at least 2 sites, 2 centimeters in diameter is seen. Systemic involvement is very important. Most common in 50 to 100%, it's liver. As far as kidneys are concerned, proteinuria, hematuria, nephritis, especially with allopurinol, myocarditis with minocycline, pneumonitis with minocycline and abacavir, and sometimes CNS and GIT involvement. And as far as the hematological features are concerned, eosinophilia 30 to 90%. It appears in 1 to 2 weeks. An important thing is if it's eosinophilia, it's likely to be a serious drug reaction with, serious DRESS. More than 1500, it's said to be toxic to the endothelial cells. Then 7 to 63% atypical lymphocytes, internal organ involvement, mononucleosis 40%, viral reactivation. So all these features are there. And of course, leukocytosis and lymphocytosis. What about the diagnosis? Now, this term was introduced way back in 1966 by Bouquet, and it was for a mnemonic purpose to describe components of the syndrome. And there are different diagnostic criteria, more or less they are the same, slight 1 or 2 additions are there by the Japanese consensus group and so on. But the current consensus, when you have a DRESS with HHV6 reactivation, then it is called as DIHS. So that's the terminology which is used nowadays for DRESS with HHV6 reactivation. So this is the scoring system by the Registrar study group criteria for DRESS. The extent of the rash, more than 50% body surface area is 1 point. Rash suggestive of DRESS is another point. Maximum 6 points can be given for systemic involvement like lymphadenopathy, eosinophilia, atypical lymphocytosis, and organ involvement. A point is given for relevant negative serological tests. So if you see Registrar study group criteria for DRESS, here you can see the lymphadenopathy, more number of sites, more than 1 site, more than 1 centimeter is 1 point. Based on the eosinophilia, again, the point system is given. I won't go into detail of it. Atypical lymphocytosis, look at the points based on the liver function tests like transaminase, bilirubin, the enzymes, also the serum creatinine and cardiac pericarditis on echo. And as far as the negative serology is concerned, hepatitis A, B, C, negative ANA, mycoplasma, and chlamydia. So this is the Registrar study group criteria for DRESS, the systemic aspect. So if it's less than 2 points, they say there is no case. If it's 2 to 3 points, it's a possible case. 4 to 5 points, it's a probable case. And more than 5 points, it's a definite case. Now, if you see these clinical symptoms and laboratory findings of the DRESS, what you see is the skin rash can go on up to 6 weeks. Fever can go on up to 3 weeks. Lymphadenopathy 2 weeks. Hepatitis 5 weeks. Nephritis 2 weeks. And if you see the viral reactivation, HHV6 2 to 4 weeks, EBV 3 to 5 weeks, and CMV as late as 5 to 7 weeks. So in general, viral reactivation can occur quite late in the course of DRESS, and viral reactivation is primarily responsible for the prolonged course of this drug reaction. This is the carry-home message you should always remember. If you see the internal organ involvement, the visceral involvement, you can see from the onset up to 6 to 8 weeks, there can be hepatitis, enterocolitis can be quite late, pneumonitis, encephalitis slightly earlier, and so on. As far as the differential diagnosis is concerned, of course, the other cutaneous drug reactions, certain acute infections, lymphoma or pseudolymphoma, collagen vascular diseases, and serum sickness-like reaction. Let's see the management. And as I said, in the management, please involve a physician. As far as the investigations are concerned, as complete blood count with absolute eosinophil count and a peripheral smear for the atypical lymphocytes, workup for systemic involvement, that's the renal, liver function test, echo chest X-ray, workup to rule out viral etiology, and inflammatory markers workup because higher levels indicate severe disease, and a high eosinophil count at the presentation of the rash indicates, or at the presentation of the reaction, is the prolonged disease. That's going to really cause a long disease. Histopathology, there are no specific features. Maybe you do to rule out the other DDs. What to do to determine HHV6 reactivation, the RT-PCR, which we hear so commonly, this terminology nowadays, that will indicate active replication. It is negative during the latency. So maybe an early RT-PCR may be negative. It's better to do a few weeks after the onset. A viral DNA detection, raised IgG titers, or a constant IgM level, all will indicate reactivation. A patch test, Dr. Dhanashri was asking about patch test, I think. So as far as SJS 10 or erythema multiforme is concerned, this does help in about 60% patients, especially in anticonvulsant and beta-lactams, and a lymphocyte transformation test, or even the FIDIA-TOP specific drug test can be done. Management, there are very vital drug history questions. Review the complete medication list, including the OTC medicines and the alternate medicines. Document the prior history of adverse reactions to drugs. Inquire about concurrent infections, especially viral, metabolic disorders, and immunodeficient states. Interval between the drug introduction and onset of rash. This is so important for any drug reaction. How soon was the drug withdrawn? That's the question. And whether there was any improvement after drug withdrawal, or what happened after drug withdrawal. So these are the very vital questions which you should ask the patient. And as far as the treatment outline is concerned, without signs of severity, if it's localized, just a potent or super potent steroids with emollients and antihistamines may do. With signs of severity, there is the systemic involvement with deranged LFTs, RFTs, echo. You need steroids, maybe 1 mg per kg per day of prednisolone, with, of course, multidisciplinary care. With life-threatening signs like bone marrow failure, encephalitis, severe hepatitis, renal and pulmonary failure, you may add IVIG to systemic steroids. No doubt the multidisciplinary care continues. And with signs of severity with viral reactivation, you add to the steroids the antivirals like ganciclovir or plus minus IVIG. And of course, you shouldn't forget the conventional immunosuppressants, especially cyclosporin or cyclophosphamide. And this outline is mainly the French recommendation for the treatment of DRESS. So in short, if you remember, the first line is steroids, second line maybe cyclosporin adding or IVIG depending on the cost factor, and third line is other immunosuppressants or maybe plasmapheresis. This is another very good flow chart which is based on the scoring, the Registrar score. So early score, if it's less than 1, it's a mild case, no need of systemic steroids, thorough investigation and look out for the progression to autoimmune disease. If it's a moderate case, maybe slightly 1 to 3 score. If there is reduction of score, then it's good, but otherwise keep on monitoring for viral reactivation and so on. And severe cases, of course, systemic steroids, immunosuppressants, IVIG, antivirals if there is a role of, if there is CMV positive and so on. So this is a generalized outline. Now, important thing about anticonvulsant hypersensitivity syndrome, no doubt you have to discontinue the anticonvulsants, give supportive care, but important thing is advise the patient regarding potential for cross-reactivity to other anticonvulsants, and also counsel family members and first degree relatives regarding increased risk. See, it's not possible to do the HLA subtyping and so on, but because of this HLA linkage, keep it in mind somewhere, explain to the patient that the first degree relatives are to be carefully observed in case they are given these drugs and so on. And of course, all other management, we know oral prednisolone, methylprednisolone pulse and so on. If you see after the resolution of DRESS or DIHS, if you follow the patient up to say 6 years, you can see these are the autoimmune problems which the patient can come across. They may get after the resolution, say diabetes or thyroid or sclerodermoid lesions or SLE. So this is the sequelae of DRESS. Death is 10 to 40%, and the most common cause is the hepatic failure. So early involvement of a physician and early management of the liver is very, very important. I would just add a note on dapsone hypersensitivity syndrome. I know DHS is something called as drug hypersensitivity syndrome, but since we have discussed all the other drugs and dapsone is the drug which we use so commonly, I've just added one slide on dapsone hypersensitivity syndrome. Again, it's a multi-organ, it's a dose-independent disease. usually not associated with G6PD deficiency or methemoglobinemia. It's 10 days to 6 weeks after starting the drug. Fever, generalized skin eruption, and liver involvement is there, and that's why it goes slightly towards our DRESS or DIHS. Renal involvement in severe cases. We have the maculopapular rashes, but even EM and TEN can be there. But peripheral eosinophilia and atypical lymphocytes, that's another characteristic, and HLA-B association. So all the features which we have discussed just now in DRESS or DIHS are seen here. So to summarize, we have seen these terminologies. We have seen DRESS. We have seen in DRESS that skin is involved. Mucosa is very rarely involved, but organ is definitely involved. Eosinophilia is a very important feature of DRESS. The concept of HHV6 reactivation, the primary or secondary, and what is its role in causing the prolonged reaction of DRESS. The genetic predisposition, which you should keep in mind, the drug pharmacokinetics, which you should be aware of causing DRESS, and the implicated drugs, and of course the management, which mainly involving multi-speciality approach. You need other physicians along with you because it's not just the skin, it's the organ involvement, and steroids and other immunosuppressants can be given. Thank you very much for a patient listening.
Thank you very much, sir, for an excellent presentation.
Great presentation, Vidyadhar. Very nice presentation, yeah.
Thank you.
Very clear. So Ritu, should we take the questions for Dr. Vidyadhar sir?
Yes, ma'am. I don't see any questions in the chat box, and I think he's pretty much answered.
Yeah, I think there are few questions in the chat box. One is the role of cyclosporin. You have already answered, I think, in DRESS syndrome. That should be the second line after steroids, right?
I think overall now, if you see, steroids and cyclosporin form the backbone of our treatment for drug reactions.
Yes.
It could be any drug reaction, but these two drugs.
But cyclosporin as a first line more in SJS 10 group rather than DRESS. Here we can do away with steroids in most of the cases, right?
But here I think steroids have a major role, especially if organs are involved, because that's a role.
I have a question for you. Which book or which article you have referred to so that we can tell our PGs to read that book and get the right.
First is the IADVL book of cutaneous drug reactions. I would just.
By Dr. Lalit. Yes.
This is a wonderful book. I mean, it's a very nice book, and it has almost given all these concepts very clearly. Second, there are a few articles on the net. Even if you just type DIHS or DRESS, you get several articles, and some of them, especially from Journal of Immunology and all, they are really good. And of course, I would like to thank my postgraduate student. She has also helped me in feeding the primary material for this.
So this book is a must in a department library. I think it's a very good book. So one more question, like you emphasize, as like Dr. Vinay Kulkarni has commented about it, you emphasize a lot about the role of reactivation of HHV6. So he wants to know, how do you monitor it, if at all you monitor it? And if at all you find that there is reactivation, what do you do for it? Like, do you treat it, or there is no way to treat it? And if nothing is to be done, why investigate the patient for this reactivation? These are the questions from Dr. Vinay.
I'm always afraid of Vinay's questions. Vinay's questions are to the point and very well. In practice or in practical aspect of this is, many a times, all our DRESS patients, they may respond very well to the treatment, but I think there may be a subset of patient who don't respond to our treatment, or who are getting this reaction for pretty long time, a prolonged reaction. That's what I stressed on. I mean, those patients, in spite of withdrawal of the offending drug, in spite of giving the best of the best treatment, still the reaction is going on. And then they want, why is this happening? Maybe in this subset of patients, we can ask for the viral studies, we can ask for the regarding this HHV6, EBV, CMV, and so on, and maybe give ganciclovir in association, I mean, with the physicians, of course. I haven't personally given these antiviral drugs, but you can keep it in mind. Like SJS/10, we all the while, especially erythema multiforme, at the back of the mind is herpes simplex virus. So similarly, in DRESS, keep in at the back of the mind HHV6. I won't say investigate in each and every patient, as it is all, I mean, it's very easy to tell. I mean, it's very easy to give a talk that this to be done, give this, and so on. In practice, if you try to give IVIG, if you try to tell all these investigations, sometimes resource limited settings is really difficult. But I think those reactions which do not stop in spite of withdrawal of the drug, do not respond as per to your expectations, even with giving steroids and immunosuppressant, think of HHV6. That's what I wanted to stress.
There is one more this thing regarding the anti-epileptics. So do you want to give any message, like you tell the physician that this could be anticonvulsant responsible for this? Now the anticonvulsant therapy needs to be continued lifelong for the patient. So they will always ask what should be the substitute. So suppose patient gets it because of carbamazepine. Can he take phenytoin? Can he take sodium valproate? Can he take lamotrigine? So you mentioned about this cross reactivity. So can you just make it more clear and give a single message to our audience that which anti-epileptic is safer in case of DRESS with others?
I think we should, all these aromatic anticonvulsants, the list which I gave, they have to be avoided, even if there is a reaction to one. The other drugs are to be avoided. And maybe then the neurologist takes we have to recommend. Bhushan, what's your take on it?
What's your take on it?
Neurologists and physicians are quite sensitized about this SJS and DRESS. If we say that this is the most probable drug and this needs to be stopped, and another anti-epileptic drug they need to stop, they are open to this. We just need to be more communicative, and they usually start, in my experience, this Levira drug, which is like quite safe and a good anti-epileptic drug also, levetiracetam. So they usually shift levetiracetam.
And even valproate in some settings, because valproate is not in the aromatic group. So maybe phenytoin and carbamazepine should be avoided if the patient is showing reaction to carbamazepine. Phenytoin should also be avoided. And I think the third one, the phenobarbital, right?
Phenobarbital.
Yeah. So valproate or levetiracetam would be the option that we can tell this.
We have to involve the neurologist. You yourself can't do that.
Yeah. And there is a question regarding the DRESS syndrome coming seen in patients, pregnant patients, and what is the outcome and what is the monitoring of the fetus that is required?
As far as concerned, if you take my opinion, my main concern would be the mother. I won't give a second thought about the fetus, he has not yet seen the day of the light. So I won't think much about it. The main aim would be to saving the pregnant lady. And if the situation demands that maybe because of drug exposure which we have given, there is a risk of say fetal anomalies, then termination of pregnancy may be advised. But for that, we need to do a good literature search, like how much this, say, for example, if pregnant ladies having 10 and we give short course 7 to 10 days of cyclosporine, what impact does it has on fetus? If it is a very minuscule impact and pregnancy outcome are good on literature search, after her 10 results, we can ask her to continue the steroid. But as far as DRESS is concerned, where we need to give a long-term corticosteroids, then this risk maybe need to explain to the lady and the her husband, like that we are giving long-term steroids and maybe there is some fetal risk to the baby.
Yeah, and the organ involvement is so important for the mother. So naturally, we have to care for, like Bhushan said, mother is the primary concern.
Ritu, are there any more questions?
No, ma'am. There are no more questions.
So should we move?
Then yes, move on to the last case presentation. Last case presentation is by Dr. Krupa Patel. slide is still not visible. Yes. Dr. Krupa Patel is the first year resident of Department of Dermatology, KEM Hospital. She passed out her MBBS from Bhavnagar Medical College in 2012-13, and her areas of interest are in clinical dermatology, aesthetic dermatology, and dermatosurgery. Over to you, Kripa. You can
Yes,
start sharing screen.
thank you for the kind introduction, ma'am, and good afternoon, everyone. So I'll start sharing my screen. It's visible, no, ma'am?
Yeah.
Yes.
Yes, you can go ahead.
Yes. So I'll be presenting two cases. So first case is of a just a second.
Krupa,
Yes. So first case is of a 32-year-old female patient who presented with skin lesion over trunk, face, and upper extremities associated with itching and burning sensation since 3 days. So before 10 days, she developed itchy skin lesion over buttocks, for which she consulted a dermatologist, was later diagnosed with tinea corporis, and was prescribed tablet griseofulvin 500 mg and tablet fluconazole 150 mg. So after the 10 days of starting these drugs, she developed reddish itchy lesion all over body, more in central part, with redness of eyes and whitish lesion in the oral cavity. So she consulted the same dermatologist for the same and was given oral deflazacort 12 mg, which she took for about 3 days, but there was no clinical improvement. So she was referred to us for further management. There was a history of fungal infection 2 years back, but the details of treatment taken at that time is not available. Sleep, appetite, bladder bowel habits were normal, but due to oral lesions, the food intake was decreased. Vitals were within normal limits. There was no fever or no tachycardia. There was no pallor, icterus, lymphadenopathy, or edema. Systemic examination was normal. So coming to the dermatologic examination, as we can see here in the picture, there were mainly multiple erythematous macules, mainly present over trunk and few extremities, which were confluent. There were few erythematous papules and plaques present over trunk and both extremities. And on the face, as we can see, there was diffuse erythema with scaling. Oral mucosa was involved. There were whitish plaques present over buccal mucosa with erythema over the hard palate. There was conjunctival congestion. Nasal and genital mucosa were not involved. Pseudo-Nikolsky sign was negative. So far, based on the onset and progression of symptoms and clinical examination, drug-induced reaction without systemic involvement was suspected. So to confirm the diagnosis, we ordered several hematological and biochemical investigations, which came out to be normal, except there were mildly raised eosinophils. And we also did the skin biopsy, which showed necrotic keratinocytes, basal cell degeneration, and lymphocytic exocytosis in epidermis. And there was superficial perivascular infiltration, mainly of lymphocytes and few eosinophils in the dermis. So the final diagnosis was made as per Rajiscar criteria. So out of 4 essential criteria of there in our patient, there was only one criterion was positive. So the diagnosis made was drug-induced hypersensitivity secondary to antifungal drugs. So this is the Rajiscar criteria, which Vidyadhar Sardesai has already explained very well. So coming to the treatment plan, we immediately stopped the antifungal drugs. IV fluids were given. Injection dexamethasone 4 milligram 3 times a day for 7 days was started, and along with oral antibiotic azithromycin and antihistamine. Oral care was given in form of triamcinolone oral paste and chlorhexidine gargles. Ophthalmic care was taken care of. Then moisturizer containing liquid paraffin topically. So on discharge, we had put her on oral prednisolone 40 mg, which was tapered gradually by 5 mg weekly dose. And currently, along with a supportive treatment, antihistamine and emollient. So currently the patient is on 20 mg prednisolone dose, with which she is showing this kind of clinical pictures. The erythema has reduced and she is maintaining with 20 mg oral prednisolone dose. So coming to the second case is of a 48-year-old female who presented with itchy skin lesion over trunk, bilateral extremities, and face. So 8 weeks before presenting to us, she started developing fever with pain in small joints. So she was diagnosed with rheumatoid arthritis by a rheumatologist. And she was prescribed tablet leflunomide 20 mg, tablet etodolac 300 mg, tablet methylprednisolone 4 mg, tablet diacerin 50 mg, and esomeprazole 40 mg. So after 6 weeks of initiating these drugs, patient developed itchy, scaly skin lesion over trunk and upper extremities, for which she consulted a local practitioner and was prescribed IV amikacin, cefotaxime, dexamethasone, chlorpheniramine maleate for 2 weeks. But even after 2 weeks, there was no clinical improvement. So after 8 weeks of initiating treatment for rheumatoid arthritis, the patient presented to us, and this time these skin lesions were associated with fever, redness of eyes, oral lesion, and there were many small fluid-filled lesions. The patient responded well to oral prednisolone 40 mg, which was tapered after improvement by 5 mg weekly dose. Again, on reaching 20 mg prednisolone dose, the lesions flared up and patient was admitted again. There was no significant past personal family history. Coming to the examination part, the patient was febrile. Other than that, all vitals were normal. Icterus was present. There was no lymphadenopathy. Systemic examination was normal. So coming to dermatological examination, there were multiple erythematous, papules and plaques with scaling on the trunk, with few lesions showing confluence, and in between skin was normal. There was diffuse erythema with scaling restricted to bilateral forearms. There were lesions near the angle of mouth, lips, showing erosions and crusting, suggestive of herpes simplex. The oral mucosa was involved. There were a few erosions over hard palate. There was conjunctival congestion with sticky discharge. Scalp, palms, soles, and lower extremities were spared, as we can see here in this picture. So far, based on the onset and evaluation of lesion clinical examination, we were suspecting it to be a drug-induced reaction with systemic involvement. So to confirm the diagnosis, we did hematological biochemical investigation in which the LFTs were grossly deranged. There was eosinophilia, and we also did the biopsy, which showed lichen tissue type of reaction. There was flattened epidermis, lymphocytes migrating toward the epidermis. There was mild perivascular inflammation. There was keratinocyte necrosis, basal cell degeneration. So the final diagnosis as per Registrar criteria was made. Out of 4 essential criteria, 3 were present in this patient. So the final diagnosis was drug-induced hypersensitivity syndrome secondary to leflunomide. So we immediately stopped the leflunomide. Patient was hospitalized and was given IV fluids, oral prednisolone 40 mg with cholestyramine resin which helps in excretion and reabsorption of the leflunomide. Tablet Valsivir 500 mg twice a day for herpes simplex, along with oral antihistamines and topical liquid paraffin containing moisturizer. Steroids were tapered very slowly. The patient was followed up for 6 months, during which she again had 2 flare-ups, which were managed temporarily by increasing the steroid dose. So this is the pre-post photos of the patient. So this is another case of drug-induced hypersensitivity syndrome secondary to leflunomide of a 65-year-old female, which was admitted in our hospital. And this is a case of dapsone hypersensitivity syndrome in an 18-year-old male patient who presented with extensive itchy scaly lesion in trunk extremities with headache, vomiting, icterus, and LFTs were grossly deranged. So coming to the discussion part, the leflunomide can cause delayed onset of reaction with widespread and long-lasting skin rash and systemic involvement. DIHS can present with different kind of clinical pictures like lichenotype, erythema multiforme like, papular like, pustular psoriatic type. So loading dose of 100 mg for 3 days can trigger the formation of toxic metabolites with resultant multi-organ dysfunction syndrome. So gradually increasing the dose regimen may cause adaptive changes which can reduce the chances of hypersensitivity reaction. The leflunomide is rapidly converted to its active metabolite A771726 in gut wall, plasma and liver, which is half-life of about 2 weeks, which undergoes enterohepatic circulation and biliary excretion. So cholestyramine should be immediately added in our treatment protocol, which helps in excretion and reabsorption of the leflunomide and also dapsone by interfering with its biliary excretion. So according to the newest guideline, eosinophilia is no longer an essential criteria to diagnose the case with a drug-induced hypersensitivity syndrome. Sometimes the clinical pictures of SJS-TEN and DIHS may overlap. In such cases, histopathology findings may come helpful to come to the diagnosis. So in DIHS, in epidermis, we can see spongiosis, few necrotic keratinocytes, as contrast to SJS-TEN, in which there is extensive full thickness necrotic keratinocytes with subepidermal bullae. In SJS-TEN dermis, there is mild or absent perivascular infiltration, and in DIHS, there is superficial perivascular infiltration, mainly of lymphocytes and few eosinophils. So this is a clinical comparison of drug-induced hypersensitivity and drug-induced hypersensitivity syndrome. So DIH is mainly limited to skin and mucosa. The systemic involvement is rare. But in DIHS, there is always systemic involvement, so which requires high dose of steroids for very long time and requires gradual tapering. So with this, I'll conclude my presentation. Thank you. Thank you so much.
Thank you, Dr. Krupa. Thank you, Dr. Krupa. Good presentation.
I'll stop sharing my screen, ma'am. Should I?
Yes.
Any questions, ma'am?
Question is from Dr. Mutalik to Dr. Sardesai. Is there any role of steroids after first 48 hours in cutaneous drug reactions and role of cyclosporine as a rescue? I think you have already answered this, right? So steroid.
No. I think I start with steroids as well as cyclosporine and taper steroids, but I don't taper it in say 3 to 4 days, but over 7 to 10 days. That's what I do.
And when you were talking about a long course in DIHS, this point of enterohepatic recirculation with 2 drugs, one is leflunomide and second one is dapsone, should be kept in mind, because even after stopping, at least 6 months to 1 year is a period where patient can keep on having recurrences. So that is what is another thing, like
Yeah, I mean,
yeah.
what has happened is, see, all these years we have been too much SJS 10 centric. And so we have been trained that steroids stop quickly, continue cyclosporin. But when this dress and organ involvement, all these features come, we have to continue steroids, according to me, for a longer time. That's what we should.
Yeah, I think we should bring it down to the minimum possible dose.
Yes,
And when there is a acute flare again, maybe in the second case that Dr. Krupa showed, transiently you can step up the dose and doing it. Yeah, that is what should be the strategy. But don't stop it immediately.
Yeah. So the concept of steroids, should be somewhere we curtailed. I mean, we have to use steroids because they are the ultimate.
That is DIHS and DIHS long-term maintenance with steroids is what we should recommend.
Yes.
So don't abruptly, like within 3 weeks, 4 weeks, we should not stop. We should see the response. Now, even the case that Dr. Krupa showed, the first case, now she's almost 30 days post-treatment and still the itching is there, still the burning sensation is there. So at this point of time, we cannot really taper it fast, right? That should be the take home, right? In these DIHS.
Yes, so like take home message of today, you have planned it so well. The first half of it was SJS 10, erythema multiforme, where steroids a smaller share and other immunosuppressants a larger share. And here you have to give a larger share to steroids as well as the immunosuppressant. That's what.
Yeah. And the onset also, like abrupt onset and a delayed onset. And we used to take the history of drugs for last 1 month, 2 months like that. But we have to go even beyond that. The new drugs added in last 1 year to 6 months should be considered when we are dealing with these patients, right?
Yeah.
Do you agree with this? Yeah.
Yes. So, I would just like to add one more. I would like to tell everybody that we should compliment Dr. Dhanashri for planning this drug reaction symposium, this CME. It's a wonderful planning.
I'm just a mediator. You people delivered it so well. Dr. Bhushan, do you want to conclude or give any take-home messages for the audience regarding these type of drug reactions?
Yes, ma'am. The drug reactions, it is very important to diagnose them quite early and treat them very aggressively rather than giving very homeopathic doses of immunosuppressant and oral corticosteroids. Many old-timers or many GPs, they give 20-30 milligram of oral corticosteroids, which doesn't add much benefit to the patient. So we have to use adequate amount of immunosuppressive drugs, either it is cyclosporin or oral corticosteroids, and preferably refer the patient to a nearby tertiary care center, because such patients need indoor care rather than treating on OPD basis. However, now there are few encouraging reports like cyclosporin during this SJS 10 was treated on a OPD basis by many of our colleagues, and which is a good sign. But however, that needs a very what I can say, compliance from the patient point of view also, and in a very less mild form of drug reactions. So better to refer the patient.
Yeah. And Dr. Mutalik sir is asking Dr. Bhushan the role of IV methylprednisolone in management of DIH or DIHS dress.
Yes, usually I won't prefer giving such pulsed corticosteroids in this, because these conditions need a long-term corticosteroids rather than a short course of say like for we give pulse therapy for pemphigus or scleroderma. The picture is not like that. Here we need to give adequate amount of daily steroids on a long-term basis.
Yes, even I think that we shouldn't have a very strict protocol of just, at this center, everything steroid is always given as pulses. No, it's always to be individualized. That's what I feel.
And then you can always form your own clinical judgment about a particular patient and decide about the. See, if there are no oral lesions and patient is able to take the tablets orally, we can definitely. Now that patient who had a dress with leflunomide, her bilirubin was somewhere in the range of 20-22, but only with 40 milligrams of oral steroid with episodic increase in the dose, she came out so well. So it's an individual tailor-made approach to each and every patient that we should be looking at. And Dr. Kulkarni sir also has commented that he says one of my patient required steroids for over an year, so don't be afraid to use them. That is the message that we want to convey, right? So are there any comments or any more questions, Dr. Ritu?
No, ma'am, there's just one question. Cholestyramine should be given in most of the cases of DIH. What is your...
No, it is specific for lefulinamide. She mentioned, right? It causes...
Yes, but not in Dapsone or any other drugs which
I
involve...
don't think so. What is it, Dr. Bhushan? Is it in each and every patient or it is specific for lefulinamide?
Too much of cholestasis there, only we use this cholestyramine as a bile acid binding resin. But rather than cholestasis, it is because of the hepatic injury which causes this all raised bilirubin and all that thing. In contrast to like cholestatic jaundice of pregnancy, where we use this bile acid binding resin.
Okay.
Okay. So I think we'll move on to the last segment now, which is the corporate presentation. I would like to invite Mr. Bhalerao of RPG Life Sciences for their corporate presentation.
Thank you so much, ma'am. I'll share my screen. So I will not take much of your time. I will take only 2 minutes. First of all, thank you so much for giving us the opportunity to get associated with this wonderful scientific program. So I would like to convey on behalf of RPG Life Sciences to IADVL Pune chapter gratitude and thank you so much. So basically RPG Life Sciences is a part of a big conglomerate which includes the companies like KC Infrastructure, CA Tires, Zensar, which is in IT, RPG Life Sciences, which is a part of pharmaceutical business, Rekem, which is an energy business and cable business, and Plantation, we have Harrison Malayalam Limited. So we have more than 20,000 employees all across the world, and with an annual growth of 15%, and we have revenue of 3.4 billions, and we are operating in more than 100 countries all across the world. Basically, if you see RPG Life Sciences, we are known leader in the world as well as in domestic market for our immunosuppressants, be it azathioprine, mycophenolate mofetil, cyclosporine, also in biologicals like adalimumab, and in small molecules recently we have launched the tofacitinib. So we are known for the quality immunosuppressants in India as well as in several different markets. So basically our story goes back in 1968 when we were known as Searle India, and then we known as the RPG Life Sciences. We have 3 manufacturing plants located at New Bombay and 2 in Gujarat. We also operate in active pharmaceutical ingredients where the factory is located at New Bombay. So we operate in more than 50 countries all across the world, in Germany, Canada, Australia, regulated, semi-regulated markets with employee base of more than 1,100 people. So we are listed company in the for the BSE listed public limited company, integrated company with having the API, international formulation and domestic formulation. We have operating several specialties, and in context of today's program, so we have immunosuppressant range, and we operate in dermatology, rheumatology, nephrology, and several other businesses. We are known for our employee-friendly policies. Since 4 years, we have received prestigious award of Great Place to Work, which is given by Economic Times of India. So RPG Life Sciences known for its quality products, and as you know that we operate in several markets, and we are Great Place to Work. So RPG Life Sciences believes in participating such forums. It's wonderful to get associated with Pune chapter of IADVL. So thank you so much. Over to you.
Thank you, Dr. Bhalerao. We have now come to the end of the program. But before we end the meeting, I have a few announcements to make and some people to thank. Our next CME will be on polycystic ovarian syndrome and metabolic syndrome on the last Sunday of September. Also from the next CME onwards, we will be awarded credit hours. With that out of the way, I would like to thank our speakers for the day, Dr. Sudhagar Grandi, Dr. Bhushan Madke, and Dr. Vidyadhar Sardesai, Dr. Vijay, Dr. Kiran, and Dr. Krupa for enriching our knowledge on this crucial topic. I would also like to thank our academic partners at RPG Life Sciences for making this meeting glitch-free. And lastly, my wonderful audience who joins on a Sunday morning on great numbers and makes every meeting a big success. Thank you once again.
Can come on videos so you can have last snap.
Last photo, yeah. Are we live or we are now?
Yeah, still we are live.
So can you just stop streaming?
Yeah.
Yeah, Dr. Vijay, can you switch on your video? Rashmi? रश्मी गेली का?
मॅम नाही डिटेक्ट होत नाही आता इतक्या वेळ होत होता आता होत नाही.
एक मिनिट मी मोबाईल मध्ये पण काढते जस्ट अ मिनिट. रश्मी
मॅम व्हिडिओ नाही डिटेक्ट होते माहित नाही काय झालं.
सुपर इम्पोज करू तुला. So thank you everyone, Bhushan, Vidyadhar, Sudhakar and all the 3 students from KM Hospital. It was really nice. It was very practical and useful, and I think our understanding of the topic will be better after this CME. And thank you RPG Life Sciences for your support. Thank you so much. And of course the audio visual team, that is the technical team, Mr. Rupesh and your team, we are thankful to you because it was really a smooth streaming from your side. Thank you so much.
Thank you.
Ma'am, edited video of this.
Yeah, please share it so that we
available.
can, please, we will put it on our website. Yeah.
Yes, definitely.
Yeah, so thank you, Dr. Bhushan, accepting our invitation. Vidyadhar is our own, Sudhakar is our own, but thank you so much to you. Special thanks.
Yeah, we will invite you also.
You can invite Dr. Sardesai, he is the best.
Okay, bye. Thank you. Good day.
Thank you everyone. मास्तर हेच फक्त देऊ शकणार लेक्चर.
मग चांगलं आहे ना, मग इतके जण त्यामुळे औषधं देऊ शकतात ना.
Thank you everyone. Yeah.
Thank you.
Thank you, ma'am. Thank you, Beda, ma'am.
Thank you, ma'am. Thank you, sir.
Thank you, ma'am.
And we are closing the session. Thank you to all.
Okay. Bye.
Bye.